So welcome. The date and location of the next Medical Services Board meeting. The meeting is scheduled to be Friday, April 10th, 2015, beginning at 9 o'clock a.m. at 303 East 17th Avenue, Denver, Colorado, 80203 in the 7th floor conference room. It is the policy of this board and the department to remind everyone in attendance that this facility is private property. The capacity of the room is 80. Please do not block the doors or stand around the edges of the room. Please turn cell phones off while in the meeting as they interfere with the recording equipment. If this room fills up, we'll request that the department staff give up their chairs to make room for the public. And so there are seating up here on the side that you can move up to. If you are listening via the audio stream and lose connection, please click again on the link to rejoin the meeting. There are individual testimony sheets for each rule, with the exception of rules on the consent agenda and for open forum. If you need help finding the rule in which you are interested, please ask the staff. We do limit the testimony to about 5 minutes. And then also, because we do have a full room, if we could be conscientious of keeping conversations outside the room or keeping them very low so it doesn't interfere with the recording. Okay, thank you. We'll have roll call.
Christy Blakely. Present. Patricia Gibbons is excused. Brigitte Hughes. Brenda Lacombe.
Here.
Paula Linkovich.
Here.
Amanda Moore. Here. Jenny Riley. Here. Donna Roberts. Here. Mike Stahl is excused. Mary Young. Here. We have 8. We have 4.
Okay. I will ask them for the approval of the minutes from February 13, 2015 meeting.
So, that's for last month's meeting.
Second.
Okay, we have a motion and a second. Everyone in favor, please say aye.
Aye.
Anyone opposed? Okay, we're going to have to move our agenda a little bit, so we are going to have the legislative update first, so we can give the staff an opportunity to get back to what they need to be doing.
Good morning. My name is Zach Lindquist. I'm the department's legislative liaison. Once again, thank you so much for taking me out of order and rearranging your day for me. Had a busy day at the Capitol, so I appreciate that. Today I'm just going to talk to you about 2 different topics. One, give you an update on where our department budget requests are in the process, and then talk about our department legislative agenda items. So, Dan hopefully handed out this fact sheet. Please note that this is still contingent upon General Assembly approval, but we have had our figure setting with the Joint Budget Committee over the last 2 weeks, and I think it's been very successful. Given that you have a very busy day today, I won't go through these one by one. I do think one of the biggest accomplishments, or what I'm most excited about, is on the back. You'll see for our customer and contact center requests, we're requesting 25 FTE for our customer contact center. As of December, we would have only had 10 employees answering the calls for our 1.1 million clients, so it's critical that we got this increase in staff, and the Joint Budget Committee agreed. So I'm thrilled. I think it was a tough request, and it was unanimous. Other things that are of kind of interest are, let's see, on the front page, Medicaid and CHIP enrollment simplification. This was partially approved, so the Joint Budget Committee decided to approve allowing the department to look at annualized income for particular seasonal workers or people that are making just a little bit more than they should that month, so that they're not kicked off Medicaid for that 1 month, and then they have to go through kind of health or whatever other options they have, and then the next month they're back to Medicaid eligible. That just causes a lot of churn for the client, but it also causes a lot of administrative work for both the department and the counties. So I think that was also a huge success. We are still working on provider rate increases. Just to give you an update, any providers that are paid through the medical services premium line is getting a 0.5% across the board rate increase as of today. Now, mind you, the Joint Budget Committee often sets these provider rates, and then when they see how much money they spent, they come to us as sort of their first opportunity to start finding some money if they overspent. So things could still be in flux. For providers that are part of the Office of Community Living line, so these are the 3 IDD waivers, they're getting a 2.7 across the board rate increase. We've also asked for targeted rate increases. We got about a quarter of those approved, and then the Joint Budget Committee offered some additional targeted rate increases. We're doing a comeback this morning where the governor's office and budget director goes and says, we think you should reconsider this particular request. We think some of these things are really valuable and deserve funding. So the next time I come to you, we'll have a more complete list of what exactly was funded. If we want to transition, unless there's questions about this document, I can move to the legislative agenda.
Ms. Brinkley?
Good morning. Thank you. Address the children with autism waiver, and that's been approved. We're waiting now for General Assembly. Is that as it was written with no changes? There was discussion about it being too much. Give me some information, please.
Sure. I don't know if this is the same as the legislative committee, but if we work through the chair, but so it is approved as a budget request. It does require some statute changes. So the bill is House Bill 1186. It's passed its first House committee. It's still waiting for House appropriations. But since the Joint Budget Committee, one of the members, the chair of the Appropriations Committee, it shouldn't have an issue. It's just sort of all the Joint Budget Committee bills sort of wait, and then they go as a whole through appropriations. So I don't see any concerns. It passed. In order to get a Joint Budget Committee bill, you have to have all 6 members. So it does have strong bipartisan support. It just is, and it's just waiting with all the other Joint Budget Committee bills at the moment.
Go ahead.
Question. And were there any changes? There were discussions about changes in age, et cetera. I just want to verify that there have been no changes.
There have been no changes.
Thank you. Any other questions?
So a quick update on our legislative items. Last month I talked to you about our teen pregnancy and dropout prevention program. This was House Bill 1079. It had passed the House with broad bipartisan support, 46 to 19. It hit the Senate and got assigned to Senate Finance, and unfortunately on Tuesday it died on a 3-2 vote. And there was some concerns about how it could be implemented statewide. So what we're going to do is work with the sponsor to pull a late bill. She's expressed her interest in doing that, and then we're going to add some additional reporting requirements to address those concerns, which would require providers to essentially tell the department which evidence-based program they're using, and then we would report that back to the General Assembly. We're hoping it will get assigned to Senate Health, which I think is the more appropriate committee, and then hopefully we can sort of provide it. But it was sort of unfortunate how it went down on Tuesday. There was also another bill that I didn't really talk about because it was sort of in flux with a bunch of other things. It was House Bill 1151. This would have required the department to set a floor on our provider rates to Medicare, 60% of the Medicare rate. And then for rates without a Medicare equivalent, we put 60% of the usual and customary. There's a lot of sort of logical flaws within that, but we also don't necessarily agree with the policy. We don't think setting our rates to the federal level, which is equally opportune for lobbying, doesn't necessarily make sense. So what we've asked the Joint Budget Committee to do is, as an alternative, this November we are going to look at all our rates across the board, compare them to something, compare them to Medicare if they have a Medicare rate, compare them to the private insurance rate. We'll sort of determine which data source we're using to compare, but then give them a kind of a whole picture of where we're at with our rates. And then the Joint Budget Committee is moving forward a bill that would create an annualized rate review process where we would look at codes at least once every 5 years. We can take them out of order. We can look at codes or code sets more than once in a 5-year period, but at least once every 5 years. Right now we're only adjusting codes as we're appropriated money. So I think that this gets us, as policymakers, to a much better spot of having a more comprehensive idea of where our rates are at and where are the pressure or pain points within our reimbursement rates. Sorry. So that's sort of my update this morning. If there's any other questions, I'm happy to answer those.
Do we have any other questions for Zach?
Enjoy your busy morning.
Thank you, Zach.
You too.
Okay, we'll get going with the emergency adoption agenda. I need a motion.
I move that all emergency rules that are adopted include finding that their immediate adoption is imperatively necessary to comply with state or federal law or federal regulation for the preservation of public health, safety, and welfare, and that compliance with CRS 24-4-103 would be contrary to the public interest.
Okay, and today we have Maribel Guadarrama and...
Good morning. My name is Shane Mofford. I provided some analytics on this, and thanks for sharing that with her.
Can you speak up just a little bit? Thank you.
So, happy Friday, Madam President and board members. Thank you for your time today. As President said, my name is Maribel Guadarrama. I'm the Eligibility Policy Manager for the department, and I have Shane Mofford here with me. So we are here today to present the proposed rule concerning the income standard for parents and caretaker relatives. This rule is being brought to you as an emergency rule due to the need to align with our federal regulations effective as of April 1, 2015. The purpose of the rule is to modify the eligibility income standard for the parent and caretaker relative category from the current 100% federal poverty level to the federally approved 60% federal poverty level MAGI equivalent. The eligibility system, Colorado Benefits Management System, CBMS, is also being updated effective as of April 1, 2015, to align the eligibility income standard to the 60% FPL MAGI equivalent of 68%. Both the rule and the system updates are part of the alignment with the goal of the Affordable Care Act to consolidate eligibility groups and simplify the categories for Medicaid. This change to the eligibility income standard is the final phase of the Affordable Care Act, known as ACA, conversion for this category. I would like to provide some background to give context for these phases. With the implementation of ACA, states were provided an option on establishing the ACA income standard for each population. States could either choose to go with the income standard in place as of December 31st, 2012, so right before pre-ACA, or they could go as far back as the income standard in place as of December 31st of 2009. The selection of the income standard was related to the enhanced federal match that states would draw for expansion populations. Initially, the department had opted to go with the standard in place as of December 31st, 2012, which was 100% FPL. However, once the department submitted the state plan amendment, which is our federal contract with the government, or federal government, our decision was made to go with the income standard that was in place as of December 2009. Therefore, the state plan amendment was approved at the 60% FPL, MAGI equivalent of 68%. By this point in time, it was too late to update the eligibility system and the rules to align with the approved SPA. Therefore, the department moved forward with the phase 1 by identifying the true expansion population through a back-end data process. This means that the department has claimed and reported on enhanced federal match for individuals that met the expansion criteria, so we excluded those on Medicare and those that are over age 65. In the meantime, phase 2 was queued up to schedule system changes to align with our federally approved state plan amendment. This phase 2 will cause some movement for our parents and caretaker relatives that are currently between 69 to 107%. Essentially, this group will be split into three major groups. The first group will be composed of clients who are between 69 to 107% FPL, who do not have Medicare and are under the age of 65, and will move into a MAGI adult category. In essence, this is a relabeling of these populations from a parent, caretaker, relative category to a MAGI adult category within our eligibility system. The second group was composed of clients who have Medicare and will not be eligible for the MAGI adult category. This group will be evaluated for other potential Medicaid categories. The majority of this group may be eligible for our Medicare Savings Program and for Medicare Savings Program. The third group is composed of clients who are no longer eligible for any Medicaid category. The loss of Medicaid is considered a loss of minimal essential coverage. As such, these individuals are considered to have a life-change event and may be eligible for an advanced premium tax credit to purchase a health plan through Connect for Health Colorado. We have been working with Connect for Health Colorado within our weekly HCPA C4 policy meetings to identify these individuals and provide a list to Connect for Health in order to assist these clients with purchasing a health plan. Any individuals who are no longer eligible for either the MAGI adult category or any other Medicaid category will receive a notice of action letting them know benefits being terminated. We have communicated this change with our eligibility site partners and will work together through our established processes to help identify any individualized cases that may need further assistance. And with me I have Shane here to help give an estimate of what exactly these groups that I just discussed, give an estimate of the number of individuals that this impacts.
Again, good morning. My name is Shane Mofford. I work in the finance office of the department. Anytime we make a major change to policy, it's critically important to us that we understand what the impact is on our clients. And while this is a necessary step to be compliant with our federal requirements, I think it's important that we share with you, as you make a decision, what the impacts are as well. As Maribel described, three groups. The first is essentially a relabeling of individuals from one category to another. There's no impact on benefits. There's no impact on how we currently pay for them. It's literally a relabeling of the clients within the system as we look at it. There are a lot of those clients. There are as many as 50,000, but the impact on them is non-existent, so no impact there. The second group of clients is those with Medicare. We've identified that there are a little over 2,000 of these clients. Because of where they fall and in the income range for Medicaid eligibility, and they already have Medicare, we believe that the vast majority of these clients are going to be eligible for programs in Medicaid, just a different category than what they're currently in. So we don't anticipate a significant impact on these clients. Where there is ambiguity is with a small subset of clients, literally 15 clients, and these are clients that are over the age of 64 and do not have Medicare. Now, of this subset, it's actually possible that they aged over 64 and we just haven't received notification that they have Medicare yet. So it's possible that this pool is even less than 15. But these individuals may be eligible for other categories. We won't know until their eligibility is rerun. But as Maribel characterized, they do have opportunities through the exchange as well. I think the moral of the story here is that while any change to eligibility can be large and intimidating, especially when you hear the phrase loss of eligibility, but in this case, the clients that are potentially impacted, the pool is very small, and there are options for those individuals.
Thank you, Shane. And we realized that this was quite a bit of information, but we wanted to make sure that there was an understanding on the purpose of the rule change as well as the system change. I would like to thank our partners and stakeholders, specifically at All Kids Covered, covering kids and family, and Colorado Center on Law and Policy, as we have been working with them to ensure that we are clear on why we're making this change and how this may or may not impact our clients. We have taken the questions that have been submitted by our partners, and we are currently finalizing a frequently asked questions document to be posted and distributed through our regular communication channels within the next few days. With all of this, is there any questions that we may answer?
Before we start with the questions, thank you so much. I'm a little bit out of order here, so we need to go back and get our vote for the emergency adoption agenda. We had a motion and a second. So everyone in favor, please say aye.
Aye.
Anyone opposed? Then I need a motion to look at document 1. So if I can have that motion as well.
Move the emergency adoption of document 1, MSB 15-02-06-A, revision to the medical eligibility rules concerning parents and caretaker relatives, section 8.100.4.G.3, incorporating the statement of basis and purpose and specific statutory authority containing that.
Second.
Everyone in favor?
Aye.
Anyone opposed? Okay, I think now we're...
We vote after testimony.
Okay. So I think we're back in order now. So any questions for Marivel or Shane? Mrs. Riley?
I just want to make sure that I'm clear in understanding it. So you have a grandparent who's raising their grandchild who's been on the child only. This only affects the caretaker relative, not the child.
I appreciate the question. Yes, you are correct. This is only for the grandparent, not any changes for our children whatsoever.
Mrs. Roberts?
Thank you. I have a question about the individual that was representing a group of individuals that I believe were from another population that moved into the United States. Have you been in contact with that individual? I believe he's testified twice on that issue.
I apologize. I'm not sure I'm familiar with the individual you're referencing. I'd be happy to look into it if I understand, have more information. I'm sorry.
Okay, it appears that because the numbers are minimal to 15, it sounds as though it's probably that population. But
I think I can speak to this. I believe we're talking about a different population of people. I believe it was Volunteers of America, and I think that's a separate issue than this issue.
Okay.
So,
Mary?
Thank you. So when does this become effective? Is April 1st, is that correct?
Correct.
That's it. So within the next couple of days, these notifications will be sent out to these individuals?
I appreciate the question. So, yes, the system build is actually scheduled for, it's the 23rd of Saturday, the second to last weekend this month. So I'm sorry, I'm lost on my dates, but it's scheduled for, it is this coming weekend, this following weekend. So after that build goes in, that's when all the notices will go out to our clients.
And the benefits will then, they will no longer be eligible as of April 1st, effective on April 1st?
Thank you. I needed to clarify that. Because our policy is to provide at least a 10-day notice period for our clients that are being discontinued from benefits, if the build is the 23rd, and I apologize again for the date. I'm sorry? 21st, thank you. If the build is the 21st, that's less than 10 business day or calendar days to provide them. Therefore, their benefits would terminate as of April 30th because we haven't given them enough time.
Okay, thank you.
You're welcome.
Okay, any other questions? Mrs. Blakely?
It took me a while to kind of generate that question in the brain. When we talk generally about they might be eligible for another category, what my experience has been is that they get a denial and they have to figure out the other category, that it's not quite as seamless as we communicated it. And I'm a little concerned about these grandparents, et cetera, who are already taking on additional roles in their lives to then just get a denial, and it sends them into scared. You know, it's a knee-jerk reaction to most of us that have vulnerable populations in our lives. How is that being handled? Because I heard, I'm sorry, your name, Josh?
Shane.
I was close.
Yes.
Sorry, I don't mean to make your name. I appreciate your trying and your name. because you talked about the first two categories, you said nothing about that third category, which is just being dropped off. And so not only the vulnerable of the middle category, and I'm a visual, so I would have loved a schematic on this. I tried to build one while I was listening to you. But that middle category we talked about, there's only 15, but there's also this other that's going to this other category. Help me understand how that's going to look, because these are vulnerable populations.
No, and that's a very valid concern, and I appreciate it. So for all of our populations, the way our eligibility system is set up is that any time someone's going to be discontinued, we look at the current information that's been provided to us, and we essentially automatically through the system do a reevaluation to see if they're eligible for any of our other categories. And this would be all of our Medicaid categories based on the information that they provide. So that's one way we mitigate. But then the other way is what I was mentioning is that for those that, once they go through the entire hierarchy per se, if they're no longer eligible, then there's a potential based on what the information is, that they may be eligible for an advanced premium tax credit. So for those, we're going to actually identify the specific names and cases and hand them over to Connect for Health and work in partnership to be able to identify if they're eligible for advanced premium tax credit and assistance with purchasing a plan. I realize that as perfect as I would like for all of this to run, there's going to be those one-off cases that really do need some hand-holding. So we're prepared to, as soon as we hear about these cases, our eligibility sites are prepared to handle them, and we'll work through whatever situation they may be having that may not have met all the other processes that have been established. Is that helpful? Go ahead.
Is there going to be somebody that's going to be working on this? Can we identify one person rather than just the entire? I mean, I'm just feeling anxious because the timeline's really truncated, and I just don't want these people bouncing around.
No, I appreciate that. We do have, with our eligibility sites, usually that's the first point of contact, but we do have escalation processes in place that we can continue using. There's our Medicaid inbox email that we have. And so I do have a subject matter expert that's assigned to this as well. So it's through our Medicaid inbox, through our EDO inbox, and then they get assigned and we get taken care of as quickly as possible. Mrs. Rand?
So just for your information, we at the county level we would escalate that to a supervisor if there was a problem and troubleshooting for. But I just want to clarify for these approximately 50,000 who were moved just into the adult category. Will that be done in the system, or will the eligibility sites have to actually?
That's the beauty of our system. It'll be an automatic movement. So, as we were discussing about it, it's essentially a relabeling. So it's automatically. There's not going to be any user interference needed. Again, unless I'm saying I'd like for that to be 100% perfect. There's going to be a few little cases that may need some interaction, but otherwise it's automatic.
Okay. Any other questions? Do we have any testimony on this one? Having no testimony, we'll go ahead and vote. Everyone in favor, please say aye. Aye. Anyone opposed? Thank you.
Thank you very much. Have a great day.
Okay. We'll move over to our final permanent adoption by consent agenda. If we have a motion.
We have the final permanent adoption by consent of document 02 MSB 14-04-15-A, revision to the medical assistance rule concerning long-term care, sections 8.400-8.499. Document 03 MSB 14-12-03-A, revision to the medical assistance eligibility determination rule concerning the Medicaid buy-in program, for working adults with disabilities and the Medicaid buy-in program for children with disabilities, Section 8.100.6.p and Section 8.100.6.q. And document 04 MSB 14-10-02-A, revision to the Medical Assistance Delivery System and Payment Innovation Program Rule concerning emergency transportation services, Section 8.018.
Have a second? Second. Okay, I also want to just mention to you that on document 2, there are some minor changes that took place, and I think we all were able to see those. So my question to you is, do we move forward with that and leave it on the consent, or did you want to take that off?
Leave it on consent.
Leave it on? Do we need any kind of okay, so we will go ahead and leave it on with a motion and a second. Can I have a vote on that? Everyone in favor, please say aye.
Aye.
Anyone opposed? Okay. Okay, we'll move on to the final permanent adoption agenda. If I could have a motion for document 5.
Move the final permanent adoption of document 05 MSB 14-11-19-A, revision to the Medical Assistance Health Programs, Provider Relations and Dental Program Rule concerning adult dental services, Section 8.201, incorporating the statement of basis and purpose and of statutory authority contained in it. Second.
Motion and a second, and we have Bill Heller and Sarah Tillman.
Thank you, Madam.
You don't look like Bill.
I'm not. Mr. Heller. My name is Frank Herbst. I'm the Senior Policy and Compliance Analyst in Health Programs Office, Benefits and Operations Division. I'm responsible for amending the Medicaid state plan when necessary, as well as helping benefit managers write administrative rules. I'll be working more closely with the dental team now. So Mr. Heller actually asked me to come introduce the rule before turning it over to Ms. Tillman to address the content. So with that, I'll turn the board's attention to document 05, which is MSB 14-11-19-alpha, up for final permanent adoption as revision to the Medical Assistance Health Programs, Provider Relations, and Dental Program Rule concerning adult dental services, which is Section 8.201 under 10 CCR 2505-10. If the board does not have any preliminary comments, I'll turn it over to Mr. Heller and Ms. Tillman to address the final version of the rule.
Okay, any questions before we move on? Okay.
Thank you, Frank. Madam President, I just wanted to give a quick explanation of why we had Frank come up for this particular rule when we didn't have him at our last rule. In the past, you may have remembered Max Salazar came and presented the technical parts of the rules, and so we're picking that back up and wanted to get Frank in the groove. And as you can tell, he rattles off all the numbers a lot better than we do. Deals with them in his lawyer capacity all the time. So that's part of the change that I wanted to explain to you. So as I explained at the first reading of this rule, this is a follow-up to the original adult dental rule, and we had to do some cleanup, add some things, some pieces that were in the children's rule to kind of make them same copy. So that's what we did. We did have some questions that came up after the presentation of the first rule, and Sarah, who's on my staff, has done some research and I think presented the board with some responses on that, pretty lengthy responses, and so I'll walk through what we found out about that and why we stuck with certain things that changed. I think there was one other item that we just updated. So with that, if you don't have any other questions for me, I'll turn it over to Sarah.
Any questions? Okay, Sarah.
Good morning, Madam President, members of the board. My name is Sarah Tillman. I am the Medicaid Dental Program Operations and Policy Specialist. That being said, thank you for having us here today to answer the questions that were brought up during the first reading. I think I I'm hoping that the memo that was sent out to you earlier in the week really did a great deal of help in explaining a lot of the technicalities, a lot better than I could hear verbally today. So that being said, I just wanted to recap the major themes that we were presented with during the first reading and the department's responses. In the memo that was sent out, I believe, by Judy Carey to the members of the board, we did, on page 3 of that memo, the March 6th memo to stakeholders, go into great detail to explain those oral evaluation frequencies. There was a lot of confusion. You saw me really mess up my attempt to explain it here, so I thought best to just provide it in writing. Essentially, we are expanding the frequencies, but we're trying to do it in a very thoughtful and responsible way because of the $1,000 annual limit on the adult dental benefit. We don't want everything to be eaten up by oral evaluations and x-rays. We want our clients to be able to get treatment. So keeping that in mind, we had some great advice from our dental directors at our Dental Administrative Service Organization, and that was what we've outlined here, and that is hopefully a great explanation of what is in the rule itself. Any questions on those oral evaluation frequencies? Okay. Great. Then I'm going to move on to the actual items that were brought up in the testimony from our stakeholders on February 13th. It is related. It was specifically to oral evaluations. We discussed the frequency around periodic oral evaluations for established patients, and that is on page 2 of 14 of your clean copy this time. And that would be lines 27 through 32. The reason the department chose not to change the frequency at this time is that while we understand the concern around an independent hygienist performing this and then a dentist needing to review the charts for treatment planning purposes, that is really something that's coming in the future, we believe, as part of the virtual dental home model that this department is partnering with the dental stakeholder community on and making sure we build it really well from the ground up. It's just a little premature. We've committed to probably coming back before you here again and addressing probably a few different rule tweaks and adjustments we'll need to make to make our program meet that future model's needs. But the model's not fully done being designed yet, so we can't speak to that yet in our rule. In case there are any other co-location projects in place that we're not aware of, and as of right now we're not aware of any, our vendor, again, our Dental Administrative Service Organization, has a smaller scale systematic approach we can take on a case-by-case basis, and we can address those as we need to, while the fuller model and virtual dental home concept is being developed by the dental community. Any other questions around that?
Can I tell her again where that is in the rule?
Of course. Page 2 of 14. I don't always translate to your iPad page numbers quite right.
That's right.
That is right. Woo-hoo. Okay, so page 2 of 14, lines 27 through 32 would be the procedure in question.
Got it. Okay. Thanks.
If there's not any other questions around that item, I'll move on to the second point that Dr. Ketchum made during her testimony on February 13th. And we heard loud and clear the cry to consider greater frequency limitation around full mouth x-rays, formerly known as intraoral complete series radiographs. And that would be on page 4 of 14, lines 21 through 25. While we understand the concern and and we believe that the concern is valid, this is, as we said many times during the first hearing, a brand new program with a different funding mechanism than others, with an annual limitation on the benefit, which is different from any other. And the 5-year, once every 5-year limitation is what was vetted in 7 months of benefit collaborative stakeholder meetings that these stakeholders were present at, and it is very similar to what you will find in commercial markets. That all being said, we recognize that our population can have special needs. And we are committed to evaluating the utilization data we'll get during the first 2.5 years of this program. No one's going to run up against a 3 versus 5 year frequency limitation difference for a little while yet. So we have this great opportunity to look at data and make a data-based decision here in the future. And we're committed to fine-tuning our program as needed. So that is where we landed as of today. I think another really important reminder is, again, the uniqueness of having a $1,000 annual maximum means that we had to really get into the weeds of what can a member be billed for a non-covered service? What is a non-covered service? Well, once a Medicaid adult client maxes out their X-ray limitation, that would fall under a non-covered service, and payment can be arranged with the provider. We encourage our providers to, charge our clients very close to the Medicaid fee schedule, if not at it. But those are some of the things to keep in mind. That and I can tell you, a full mouth series right now reimburses at $54.17. It's not cost prohibitive. So, that being said, that's where we landed on that. Any questions at this time?
Any other questions? We appreciate you taking that feedback from last month and coming back to us and giving us an update. And I really do appreciate you looking at special circumstances, because we do have those individuals that don't fit in, the every one size fits all.
Absolutely.
So thank you. Do we have any testimony for this one? Okay. We have Marilyn Ketchum.
Good morning.
Good morning. Welcome. If you can just state your name and who you represent.
Okay, I'm Marilyn Ketchum. I'm a dentist. I'm representing the Colorado Dental Association, and I also work for Denver Health as a clinical provider. I just wanted to say thank you, because I think there's lots of really good things in this rule to start off with, and it's good to meet you. So, kind of looking at the one rule that is really concerning for me is, and I'd like to kind of maybe update you on the co-location project, that isn't something for the future, that it's actually happening now. Denver Health currently has 15 school-based programs that are being utilized by hygienists. They're going into the school and actually performing these oral evaluations right now for us. And then once they're out in the field identifying school-age children that require dental care, referring them to our 5 other clinics. Additionally, Delta Dental just authorized 12 grants to have co-location programs for hygienists throughout the state of Colorado. So that's a total of 27 programs that are currently in existence, and it doesn't include independent hygienists or that are going into nursing homes and providing care, and also those people who are in just independent dental hygiene practice itself in the state of Colorado. So when you kind of combine all of that, it's actually going on right now. And then we need a mechanism for which doctors to be able to identify disease, because hygienists are not allowed to diagnose at this point. They're able to do the oral exam and the screening, but then the doctor has to take the films and do the diagnosis again. So that limitation, I think, is not just the virtual dental home that is coming, which is going to add to that. It's also, this is in existence right now. So just making you aware that those programs are actually in existence now, and that there is a need for that. And then, just speaking to the full mouth series, I really appreciate the fact that you're willing to look at that, 3 years from now, because now all of these mouths that are coming in are going to hopefully look vastly different 3 years from now, and we are going to need to update our radiographs. And while it may not be necessary now, they're not going to be able to bill for it either right now. So if I charge for a full mouth series, I can't bill again for 3 years. And so, but we are going to need to update radiographs, because hopefully these mouths are going to look vastly different than what they do today. So I kind of look at that and say, I think those are 2 things that I'm still really advocating for, because we need them now in order to really provide good care for our patients.
Sarah?
Madam President, members of the board, Dr. Ketchum, I hear your concerns. I would like to just remind everyone this is the adult dental rule. School-based co-location projects, if those are children populations, these are not the frequencies and limitations that they're held to. So just if they're in different populations, and through EPSDT, they would always get what they need. And additionally, this procedure for children does have the per provider or per location. So I think with the children, they're more covered. Again, we'll address the adult location specifically as we did in this memo. And if you want to contact us directly with those, we have been in contact this whole time. We'd be happy to work with you. Like we're saying, the ASO has a way to address this, that we don't have to do it in rural at this time. It's not an all or nothing scenario.
Okay, I guess just the clarification for us, because there are the Delta Dental programs, the nursing homes, and the independent hygienists, which are, that's another, the Denver Health System, which is, there are ones that are in school-based programs or children, but all the others are adult-based programs. And so looking at, it's already in progress, and knowing what is going to be the assurance as we're trying to increase provider rates, for Medicaid and acceptance of Medicaid, they're going to want to know that they're going to get reimbursed for what they're providing in order to sign up. And so when you say, well, we'll just do it on an individual basis, that's really, I understand that we can do that, but they don't know how to do that through DentaQuest and trying to figure that out if it's not in the rule.
I thank you,
Sarah?
Madam President, members of the board. I do hear what you're saying. I would like to speak with you after this hearing about those. As well as I really have to emphasize that I'm looking at utilization data. I don't see an issue with this particular procedure at this time. Additionally, I feel like I'm being asked to solve a larger problem, and that is I really believe that the trade associations are handling this better than I ever could or will, and they represent their members very well, but I can't through this rule, get involved in what provider gets to bill what procedure, especially if through co-location, through telemedicine, which I think we're all very pro, and so that's why I'm going to work from a systems perspective to address any current project where we need to address this. But long term, I know with the virtual dental home model work, this is something that's being hashed out, and I'm not part of that. I don't represent any of these providers. I don't have an opinion or say, nor would I want one. So I'm more waiting to hear what they figure out in terms of who does what procedure and who bills what procedure. But I just need to remind everyone, ultimately, my concern with the adult population is, if every provider is wanting to bill just for the initial oral evaluations and x-rays, which they have every right to and should, where do we balance the $1,000 maximum and how far it gets our clients? And can we get them past oral evaluation and diagnostic and still get them treatment in that year? And I don't know yet because I don't have data. I really need a year's worth of data so I can make data-informed decisions.
And I think, Sarah, you're absolutely right, because it is a new program. We don't have the data to really back up anything that we're trying to say here until we see what those numbers are, and then how can we then consider, some of these other options. So I totally agree with you, and I really do appreciate the fact that you're willing to work together and try to come up with a solution that we could look at. So, Dr. Young?
Yes, Doctor, I forgot your name.
Ketchum, Marilyn.
Ketchum. So if I understand correctly, you're in favor of this rule as it stands and are asking that there just be further consideration of these benefit limits in the future. Is that correct?
I like the rule as it stands. I think there's lots of great things that are happening with it. The one thing is this is that is impacting this year. When a year of benefits is this issue with the co-location project of how many exams and who bills for them, and then they're not billable because they bundled the exams together in the rule. And so that's the part. Everything else, I think, it's like, let's just wait and see. We can work with things, but it's just that particular one, because in order to get the patient's care, they have to have an exam. If they don't get an exam and you don't have providers coming in and signing up for the program, then the patients aren't going to get the care. And so that's just, to me, that's a stumbling block that I'm hearing from, FQHCs as well as private providers, like when you're looking at corporate dentistry, that those are the things that they're putting, the gentleman that testified last time, I can't remember his name, he does a bunch of nursing home, he represents somebody who does a lot of nursing home work, where they send hygienists in to do that, and then the dentist does the work. So if they can't get the exam, that's the thing, is if we can get them into the exam and get them the care that they need. And we're already
Dr. Malinkovich?
Thank you. I appreciate take your concern that you raise about co-location models. Clearly, however, that's the minority of dental practice right now. I think it is expanding, and I think it will expand a lot as time goes on. Virtual dental rooms, I think. So it seems to me that for the sake of what we need to do right now, passing this rule would make sense because of all the benefits associated with the rule. But continuing to work on how we bill for and pay for co-location models would be important to do as well. Would you agree with that?
Yeah. But, and I know that you're willing to work with that, and that would be great, because there's lots of stuff that's going on out there that I think it's going to really impact providers.
Any other comments? Any other questions? Thank you for your testimony.
Thank you.
Okay, with that, we'll go ahead and vote. Everyone in favor, please say aye. Aye. Anyone opposed? Thank you. Okay, moving on to document 6.
Yes, I move the final permanent adoption of document 06, MSP 14-09-09A, revision to the medical assistance community living rule concerning Colorado Choice Transitions, a money follows the person demonstration, section 8.555, incorporating the statement basis of purpose and specific statutory authority contained in the records.
I have a second. With that, we have Nicole Storm and
good morning, Madam President.
Tim, right?
Tim Cortez, yes.
Okay.
My name is Nicole Storm. I'm the project manager for Colorado Choice Transitions. And this is the MFP project director, Tim Cortez. So we're here for the final adoption of the CCT rule, and the revision is intended to do two things. First, we're updating the rule to better reflect how the program operates by bringing the rule into alignment with the current processes and procedures. Second, we were removing 2 of the 14 demonstration services that are available for clients who participate in the CCT program. The first is the transitional substance abuse benefit, which is now available through the state plan. And the second is the transitional specialized day rehabilitation service, which had low provider enrollment, 0 utilization, and we believe other services are available to serve clients, for example, adult day programs. Funds allocated for these services will be redirected to other demonstration services used to support clients during their transition and through community living. So at the rule's initial reading last month, some concerns were raised about the enrollment process for CCT. There was a suggestion made to change language regarding the CCT enrollment process at section 8.55.6A and B. In order to participate in the CCT program, an individual must sign an informed consent, recognizing their participation and the rights and responsibilities of the program. The suggestion was made to strike 8.55.6B and add the word "or" to 8.55.6A, which would then read, clients or guardians shall demonstrate by signature that he or she provides their consent to participate in the CCT program. I believe that is what you received in your packets from last week. Based on additional feedback that we received this week and in consultation with the Attorney General, we put forth some additional revised language. And that, our attempt was to further clarify the language with regard to section 8.55.6A. The new language that we proposed reads, clients or legal guardians, if appointed, shall demonstrate by signature that he or she provides consent to participate in the program. And I believe that is what you have in your R page that was handed out or will be handed out.
It's on our.
It's on the tab.
It's on the tab. It is. Yeah, it's on here. So now we'll need a vote, right? Our page.
We have the R page and our iPad.
if you want to look on there with the adjustment.
Okay, so now we'll need a motion to include the R page. If I can have a motion.
I so move.
Second?
Second.
Do you need to vote on this one, Julie? Okay. So all those in favor of the motion and the second, please signify by saying aye.
Aye.
Any opposed? Okay. So everyone has the R page in front of them, or it's on your tablet. And seeing that we do have a number of written testimonies, I think everyone has had the opportunity to look at the testimonies. And then, Dan, do we have? Okay. And seeing that we do have about 8 people signed up for public testimony as well. So we'll go ahead and start with let's go ahead and continue. Nicole, you want to go ahead and just talk about what the concerns were with the language and just kind of update us?
Sure. So initially, we had presented a draft of the rules for Advisory Council for their feedback and comment. And at that time, the Disability Law Colorado had made some suggestions to change the language to let me see if I can actually pull up the language itself. But essentially, I believe that the Disability Law Colorado would like is there a member working? Tim, if I could get some help from my boss here.
Certainly. From what I recall, the Disability Law Colorado, they changed their name from the Legal Center, so I'm just trying to remember that, had suggested that they wanted to see that there was greater participation of clients in the transition process and the selection process or enrollment process, and that make sure that their rights are respected in relation to Olmstead as well as the American with Disabilities Act. And so in that regard, they wanted to make sure that the client at least had the opportunity to explore the opportunity to transition, and that the guardian would be involved should the client show interest. And I believe the primary concern was that the guardians felt that they needed to be involved every step of the way in terms of that enrollment process and making sure that they're informed along with the client about those opportunities at the same time. So I think that's primarily where I guess kind of the tension is between the role of the guardian and the role of the client in helping to, in making the determination that they would like to proceed with the Colorado Choice transitions and moving from a institutional placement to a community setting.
Any questions? Thank you for that explanation, Tim and Nicole. So with that, we'll go ahead and start with the testimony. We're going to have Jerry Bates. And since we do have quite a bit signed up, we may have to limit the time that you testify. I want to be conscientious of everybody's time, so if we could limit it to probably like 3 minutes, that would help to get everybody in.
Madam President, I'll try to be respectful to that. I'd also like to thank Madam President and the Medical Services Board for the opportunity to speak. My name is Jerry Bates. I believe the Medical Services Board has received multiple comments, written form, against the changes regarding guardians as it applies to the CCT services. Revisions to document 06-MSB 14-09-09-A CCT, page 7, section 8.555.6.A. After reading the revised wording in document 06 MSB 140909A CCT, page 7, section 8555.6A, seems like we got a lot of numbers to cover here. I have concluded that by removing the wording guardians and adding clients or guardians, if appointed, shall demonstrate by signature, which was one of the original wording changes. It's taken away the legal rights of the guardians as stated in the Colorado Uniform Guardianship and Protecting Proceedings Act. The Guardianship Act, Colorado Revised Statutes 15-14-101. I can't imagine when it would be okay for a client who is developmentally disabled to sign complicated legal documents which would affect their future care and services without the consent or knowledge of their legal guardian. What was the purpose of striking 8.555.6.B stating guardians shall demonstrate by signature and adding clients and guardians, if appointed, shall demonstrate by signature? We are the guardians and parents of a daughter who is a resident of the Wheatridge Regional Center group home, and she does not have the capacity to understand or sign complicated legal documents of any type. Our daughter is 100% dependent on her legal guardians to ensure that she receives the proper care and services that her fundamental human rights are protected. I appreciate the opportunity to address this board our concerns and hope that you would not allow revisions in wording which could be a detriment to the client's long-term care. And I'm speaking on behalf of myself and Carol Bates, the mother of our daughter Teresa Bates, who's on Zenith House. I sincerely hope that you would take this very seriously. And I know you've got plenty of comments, and I'll cut my time short, but we're very adamant that this is absolutely wrong. This is not the way to proceed. And I appreciate you'll take that into consideration. Thank you.
Thank you, Mr. Bates. And again, we are very conscientious to make sure that we are looking at both the guardian and the individual and making sure that we have the right language in there that will include both pieces. So thank you.
Yeah, if I may, Madam President, this, as I've stated, this does disregard the respect to the guardian. I believe that really does eliminate that, because when you go or, the client or guardian, and then it says or appointed guardian, which was the last verbiage that I heard, that appointment, I believe, is necessary through a judge. Well, myself and my daughter's mother are both co-guardians appointed by the judge, so we are appointed guardians. But in a situation where there are guardians that are not necessarily appointed, they're only there as advocates, I think this whole word change is just demonstrative of eliminating guardianship. And I thank you for your time.
Thank you for your time.
I just wanted to know, just having looked at the comments, I don't think it was the intent of the rule to trump probate guardianship law at all. Even if we wanted to, we couldn't. A rule doesn't take precedence over the probate court orders. So, I just want to squash any ideas out there that is the intent of this rule. So I think we just need to focus on what's the right language. And the point is, we just need to make sure whatever the authority exists per this court order is what's being complied with. We all know a guardian cannot force care on a ward that the word disputes. And if that's the case, it goes back to the privilege judge. And so there wasn't any, malintent, so I just think we need to come up with the right language to make sure it's clear. Makes sense?
I just want to make sure I understand what you're saying. If a guardian has been appointed and has responsibility for overseeing the person that they're overseeing, that would take precedence over decision making.
Yeah, I mean, if that's what the order states, I mean, usually there's a guardian appointed because the person is not capable of making those kind of decisions.
I just want to go ahead.
No, but they still can, force care on the ward that the ward doesn't agree with.
But let's just play out a scenario. So I'm the guardian for a developmentally disabled child of mine, and my child signs that they want to do something that I think is not in their best interest. I can overrule that if the court says I can.
Right.
That's right. So the law doesn't affect.
Exactly.
It's the courts.
Exactly.
And the court on guardianship.
Exactly.
Okay. Thanks.
Thank you, Jennifer, for that clarification.
Can I just ask one thing as well? You mentioned that the word client was added based off of a recommendation, because I'm assuming then there are scenarios in which a client would have the opportunity to make this decision, and based off the old rule, by striking it out, we didn't have that capability. Would that be correct?
The word client has always been in the rule.
Okay. And we kept it.
We kept the word
because there are situations in which that client would have the capability to make that decision.
I would say 95% of clients who participate in CCT are able to sign the consent form on their own behalf.
Madam President, I would check with that.
Mr. Bates, if we could continue, and then...
I'm sorry, but that is not right.
Yeah, we need to continue, and then we can talk about this later.
Madam President, just in response to follow up with Nicole and board members. So what Nicole was referring to, 95%, is we don't just target people with developmental disabilities. We're targeting people with mental illness, people with physical disabilities, and older adults who are living in nursing homes, not just regional centers. And so the majority of the clients that have transitioned through mental health person, which we roughly have about, I think it's 83 now. The majority of those are people without guardians. We've only transitioned roughly, I think, 3 to 5 from regional centers, and we have, I can't remember the exact number of people with intellectual disabilities that we've transitioned from nursing homes, but the large majority have been people that do not have guardianships.
Thank you.
Thank you for that clarification.
Okay. We'll continue with Veronica Roberts. Good morning. Welcome again.
I think that we all are trying to get to the same place, what's best for these people, intellectual and developmentally disabled people. What I think we're objecting to is the ambiguity.
Veronica, can I stop you? Can you go ahead and state your name? And
I'm sorry.
That's okay. I'll write you represent. Sorry.
Veronica Roberts. I'm the guardian for George Augenbaugh, who is a Wheat Ridge Regional Center resident at Depew House. Okay.
Thank you.
Okay. We're all on the same page pretty much, except for how the language will be written. The way it's proposed now is very ambiguous. It can be interpreted 2 different ways, because it reads, clients or legal guardians, if appointed, shall demonstrate by signature. That could mean if there's a legal guardian, then that person needs to sign, or it could mean clients could sign even if there is a legal guardian. I mean, it's ambiguous, and that's what the problem is. So I think instead of an or, we should have an and, because that takes away the ambiguity altogether.
So are we looking at and or?
No,
not just and.
Just get rid of or. Clients and guardians, if appointed, shall demonstrate by signature. that he or she provides consent.
So then we're looking at two people providing consent.
Well, I know that y'all want to keep the word clients in there because, after all, that's what the rule is aimed at, is those people, the clients of the state.
Right, and I think that you're absolutely right. We're all trying to get to the right language here.
Exactly.
My concern is if we put "and," are we saying that both people now have to sign?
And would so imply, yes. Okay. And it leaves no doubt that the guardian concurs because they have signed the agreement to the consent.
So could we look at client and guardian if appointed? Because some of them may not have a guardian.
That's exactly right.
Correct.
Clients and guardians if appointed shall demonstrate by.
Okay. Mrs. Blakely?
Ms. Blakely, for clarification purposes, in the developmental disability system, I'm on a human rights committee for one of the community center boards, and we do a lot of this legal side of rights. And at all times, the client, whether it's a state, whether it is an ex, is at the right to sign that document along with a legal guardian if appointed. If not, then that ex or whatever that signature is stands. And it would make sense to me to be within the same line in this document as well.
Any other questions?
That's pretty much all I had to say.
Okay.
I really hope you don't go toward a vote with this current language. That's my hope. Thank you.
Nicole, Tim, is there any concern with the word "and" versus "or"?
No.
Yeah, I think if, this is Tim Cortez, Madam President and the board, I think if we say and we have the qualifier of if appointed for the guardian,
right,
then that might be the right language. So I think that could be doable. Just as long as we're clear that for clients without guardians, they do not need to go find a guardian.
Correct.
In order to transition if they don't, if they choose to do that. So I think with the qualifier of if appointed should suffice. But I would like to hear if there's any testimony that might object to that.
Okay. Mrs. Blakely?
You could also say when appointed.
Or when appointed.
Mm-hmm.
Okay. Mrs. Wren?
So I'm thinking, this is a broad population, not just development. And so you could have an individual with a physical disability or an elderly person could be transitioned and is capable of making that decision and does have a guardian. What recourse would they have if the client wanted to go ahead and transition to the community and the program accepted them as eligible and capable of doing that and the guardian opposed that? Would they need to go to court?
Yes, that's my understanding.
Okay. Kathy Stevens? Kathy, if you could just state your name in the mic and who you represent.
Thank you. Good morning. My name is Kathy Stevens, and Veronica Roberts is my mother. We are actually co-guardians of my brother, George Augenbach, who's a resident of Dubuque House with Ridge Regional Center. And I, too, as my mother said, I think we are all trying to get to the same place. We just want to ensure that our loved ones, our adult loved ones who have guardians for a reason, that were appointed for a reason because they are not capable of understanding the legal document that they are signing. We just do not want somebody to ask, say my brother, would you like to move somewhere else? And he would say yes, and they give him a piece of paper, tell him to sign his name, and he has no concept of understanding what he's signing, and would lose the care that all the care that he needs and is receiving where he's living now. So I too agree if we were to change the language to clients and guardians when appointed or if appointed, just so that if the client does have a guardian, they have a guardian, a legally appointed guardian for a reason, that guardian also needs to consent to them participating in this program. I don't want to take away the rights of anybody else that doesn't have a guardian that wants to participate in the program, but I think this language might be, what we're proposing might cover it all.
Thank you.
Say thank you very much for your time.
Next we have Patricia Farrell.
I am Patricia Marie Farrell. I am the legal guardian and sister to Susan Farrell, and I have an objection to the word or, because in our case, my sister was given an or before. Even though I'm guardian, she was placed in a dangerous situation. It took me over a year to get her out of it. All you have to do for Susan is say, write your name and hold the top of the pen and spell it, and she'll try to do it. It'll take the whole paper, but she will do it. But to have or in there takes all my rights away, and I would never want to hurt again like she was over 2 years ago. And this whole thing scares me, the and or, the or. It's got to read something to protect both sides.
Correct. Thank you. Thank you. Next we have Kelsey Meredith.
I'm Kelsey Meredith. I'm an attorney with Disability Law Colorado. For those of you who don't know, Disability Law Colorado is charged under federal regulations with investigating allegations of abuse, neglect, and rights violations of people with disabilities. And my organization believes that the CCT regulations that require guardian consent for participation, both as written and as proposed, are illegal under state or federal law. Now, we sent out a memo about this yesterday with regard to the federal law argument, so, excuse me, a little bit of a cold. To respect everybody's time, I'm just going to refer people to the memo to understand the federal law and address the guardianship issue. Because people are very concerned about this for some very good reasons, and I think we all need to be sensitive to those issues. So, under the guardianship statute, it's in section 1514.316.4. That's the Colorado guardianship statute. It says that guardians have, of course, broad authority to make placement decisions. However, they cannot commit a ward to a facility against the ward's wishes, and they cannot require the ward to engage in certain care and treatment against their wishes. And I should clarify that this is applying to individuals with developmental disabilities and mental illness. If a guardian wants to commit a ward or wants to force care and treatment, they have to go through the civil commitment procedures. Right. What CCT does is that it provides many people with disabilities who are in nursing homes, intermediate care facilities, and a few other facilities with the opportunity to be assessed to determine if they can live in a less restrictive environment and possibly to move to a less restrictive environment. Now, under the federal law, the ADA, the Rehabilitation Act, Department of Justice regulations, and Colorado's own statutes, individuals with disabilities have the right to live in the least restrictive placement. So what we're doing here, what we are proposing, is not taking away guardian rights. In our view, what this regulation is doing is impermissibly expanding guardian rights so that they have the ability to do something that is forbidden under Colorado statutes. And under the federal law argument, the state is administering a program that violates the ADA and possibly overstep. So I know a lot of people here are worried, okay, my ward does not know what they're signing.
And this exists. I've seen it. I think anyone who worked with individuals with disabilities in facilities has seen it. What they need to do if they want to stop the CCP process is to initiate a civil commitment procedure. So, for example,
can we continue?
So let me just reiterate that. Okay. If a guardian is opposed to the CCT process under Section 15-14-316-4 of the Colorado Guardianship Statute, they have to initiate a civil commitment procedure. To answer your question, I believe, if we are allowed the guardians to end this process right now, what that will do is require the person with disabilities in an institution to have their guardianship modified. Now, the problem with that is we are placing the burden on an individual with disabilities who also lives in a facility. And if they live in a facility, they don't have access to the same kinds of information that you and I have. We are placing the burden entirely on the individual with disabilities to navigate a very complex court process in order to realize their right to a least restrictive environment. And that right to a least restrictive environment is well established in civil rights legislations, and it's a human rights issue as well.
Thank you. We're at our time. Okay, and we appreciate your testimony. Any questions?
I have a question. I'm not sure. I understand your belief that on a legal basis this is not correct. But I don't understand the alternative, or what option you would recommend that how the rule should read.
Well, in the memo that we sent out, we did put in proposed
language.
In the memo we sent out, we did put in proposed language, and I have 20 copies of that memo with me if anyone would like.
What I wanted to just verify is, if we adopted that language, you would feel that would be correct?
I believe that would bring Colorado into compliance with the state and federal law.
What I'm not sure about is would it satisfy everyone else?
Well,
I don't know how to answer that.
I'm certainly not going to satisfy everyone today. I know that for certain. All I can do is say that we have certain civil rights statutes because civil rights are important, and we need to respect those statutes.
Well, I understand that. I just want to thank you.
Okay.
Mrs. Roberts, would it be possible to have those with vested interests that have loved ones involved in a situation where they're feeling threatened because of their rights being usurped because of law? If the stakeholders could meet with the department and perhaps attorneys to develop some sort of ability to ensure that people with, particularly those that are not with developmental disabilities or intellectual disabilities, I should say, sorry, I should correct myself there, so that their loved one is still safe, but it doesn't impede the ability for anyone else that has the capacity to make this decision. Is that a possibility to come to some level of agreement?
Yeah, what Nicole, Tim, and I have all been talking about is getting together with attorneys, with concerned guardians, so that we can develop language that we feel would be legal and would address those concerns. Disability law, Colorado, we don't want to hurt anyone. We don't want to frighten anyone, but we have to advocate for the rights of the disabled.
And I understand both points. Thank you very much.
And I would be very happy to be a part of that meeting, and I'd be happy to answer any questions after I'm done here as well.
Okay, we'll go ahead and let Tim and Kelsey and Nicole look at setting up your meetings. And
yes, I believe those meetings that is being scheduled as okay. That's in the works.
I guess the other question to follow up is, can we postpone action on this rule while that occurs? I mean, is there any urgency to adopt this rule?
No, other than we were simply trying to clean up, clean up the rule and bring it into alignment with what we're currently doing with the program. The substance abuse benefit is now available through the state plan, we're not technically supposed to have that as a part of our HCBS waiver programs. But what I have been doing is just outreaching to our intensive case managers to let them know if they have selected to choose the transitional substance abuse benefit to go ahead and access that through the state plan. So if that's acceptable to Tim, that works for me.
Mrs. Wren?
Do we have to table the whole rule, or can we get the other benefits flowing by approving the rule with the exception of the changes to that segment?
I believe we would have to table the entire rule.
Okay. Mrs. Roberts?
If I may, I would offer a motion to table this rule until the stakeholders are in agreement with the language or as close as we can come.
I would second that.
Okay. So we have a motion to table the rule in a second for a future date. We don't have a specific date in mind. Correct. Okay. All those in favor, please say aye. Sorry.
Actually, I think we should set a date and not have it a future date. So, I was going to suggest 2 months.
Okay.
So 2 or 3 months?
That's what I was thinking, May or June.
May or June?
Tim, Nicole, will 2 months be, or 3 months? You want 2 or 3 months?
Madam President, that should be sufficient.
So, what's 3? 2
or 3. Let's say 3 months just to be safe.
Okay. So, go back to the motion. The motion is to table the rule for 3 months. We've got a second. Everyone in favor, please say aye. Aye. Anyone opposed? Okay. Do we continue? Okay, great. So we'll go ahead and finish with the public testimony. We have probably 4 more that would like to testify. So if we could have Tim Hudner. I hope I said that correct.
Thank you, Madam President. I'm here in the role of a parent today, although I do serve on a number of boards and commissions that advocate for the disabled and mentally ill. And actually,
Tim, could you just repeat your name, even though I already said it?
Tim Hudner.
Okay, thank you.
And I was here actually to ask for you to table this motion. So I don't want to be somebody who doesn't take yes for an answer, but I just want to clarify a couple of things. One that was said earlier. One, in answer to your question, Mr. Milinovich, Dr. Milinovich. The proposed rule changes do change the relationship between guardians and the courts, in that right now a guardian could oppose the movement from an institutional setting, and the individual would have to appeal that to the courts. This rule change would mean that the shift of that burden to appeal to the courts goes to the guardians. So it does alter the relationship between the guardians and the courts from what exists today. And I just want to make that clear. And the statement, I think, that it's too much of a burden for an individual and an institution to access the courts and to avail themselves of that appeal process kind of understates the difficulty of guardians to do that as well. In fact, I have a son who lives in the Regional Center at Grand Junction, and I would say he has more access to legal supports and legal services than most guardians that I've met. So I don't think it's fair to say that it's just a matter of shifting that burden to someone who can more appropriately accept that burden. So those are just 2 points of clarification. And the third point I'd like to make is regard to the legal argument that you just heard from the Legal Center. I'm not a lawyer, but that argument didn't sound right to me, that guardians should have no say in the decision to move somebody from an institution. So I did engage my own lawyer, and I asked him to write some analysis of that. And I was not surprised, and maybe you won't be either, but he disagreed with the Legal Center's argument, and he felt that the proposed rule changes would be in violation of Colorado state statute, and that the Medical Services Board, by form, cannot adopt rules that are in violation of Colorado state law. So that provides some difficulties. In fact, those rules would be void if you did so. He also argued the point about Olmstead, that Olmstead intentionally was silent about the role of guardians. Their intent was not to overrule state statute when it came to guardian law. And so Olmstead should not be used as an excuse to deny guardians their rights or to diminish the power and authority of guardians. So those are the other points I wanted to make. Thank you very much for
Thank you.
doing what I wanted before you even asked it.
Okay, I think we will go ahead and take a 5-minute break. Okay, we'll get started again. So if we could have everyone back to order, that would be great. Okay, we have, we'll continue with the testimony on document 6, and we have Julie. Sorry, Julie. I should know this.
You should be able to read my scribbles by now.
Well, welcome. Please state your name. The other thing, too, is to try to be conscientious to everybody's time. If you could shorten what your testimony is.
So you remember my testimony, Madam Chair. Okay. My name is Julie Farrar, and I'm the policy analyst for the Colorado Developmental Disabilities Council. And I'm going to start by saying that we have not taken a position on guardianship. What we are here today is take a position that is probably matched by many people in this room, that the stakeholder process was not followed, and that there are a lot of possible unintended consequences for people with developmental disabilities and their guardians who are in the regional center, not through HCBS services. That was not considered, and they were not part of the discussion. And there were also probably members of key people, department leaders that weren't part of this discussion either. And I've been doing this for many, many, many years, and I believe that in the last 5 years we have moved forward as far as the departments making the different departments, Colorado Department of Health and Environment, the Department of Human Services, Healthcare Policy and Finance, Division on Developmental Disabilities, all agreeing that we will have a very thorough stakeholder process and vetting, and that is not what happened in this particular situation. So all we are saying is we want that process to be followed. We agree with the idea of tabling this so that the right people can get together so that we can find a solution to this that doesn't have great intentions and actually ends up harming people.
Okay. Thank you, Julie. Any questions for Julie? Thank you for your testimony. Next we have Linda Henry, and you also have a hat that just speak.
It was kind of broken before.
Linda, if you can also just state your name in the mic and what you represent and what your opinion is on this document.
My name is Linda Henry. I am a parent and legal guardian of Darren Henry, who has been and is a resident of the regional Wheat Ridge Regional Center, has been there for 16 years. And my husband, Arthur Henry, is co-guardian. He was unable to attend today, but his sentiments are expressed in the handout that you have. And I would like to begin by what resonates with me at this meeting is we visit our son 3 times a week, and we are very devoted to him, and he likewise, and he always assertively during that visit will say, I'm at 59th, which is a residential home at Wheat Ridge, and he says it, even though his language is limited, he lets you know, I do not want to be moved. And we agree with him. Now, based on everything that has been said in the meeting, Plan A for us, based on what we see of our son and of the facility, we feel that the original language that says guardians shall demonstrate by signature, and of course we understand that we don't want to violate anyone else in the global disabled community, but we know that we represent our son's sentiments, and if his sentiments are not in alignment with what is best for him, we will be able to have a good conscience and say, we're doing this in his best interest, and he will eventually see that. I commend everyone in the committee for tabling this because it is such a weighty decision, and not only is it weighty in the sense of the impact of our loved one, and in this case our son, but it's weighty because even though perhaps a small segment of the population is impacted that have those cognitively and mentally deficiencies or needs, it sets a precedence, and I think I'm feeling it will have a rippling effect on others who are challenging guardianship to misuse it. So the language is so important. So I commend you, and I would like to be a part in some way of that discussion. I took a note. One of the speakers had said that we had done a measurement, an assessment tool that substantiated the client being ready. This is another discussion, but I just wanted to put out there that many we parents and some of the other parents at Wheat Ridge felt that assessment tool was far too expedient and one-dimensional. It did not include adequate parent input, and it only included full-blown in-crisis behavior. And I use the analogy of a pilot. He's flying an airplane, and he has tons of weaknesses that only without the support of the control tower and this support system, he would be able to land it. But without those supports, that pilot would probably have crashes. So instead of the pilot being demoted,
this is Henry.
Yes.
I appreciate your comments.
Move on because I'm on a roll. Okay, these are our fears, and these are our fears. We are fearing that based on our son's cognitive needs, and to demonstrate that, even at a site clinic meeting or an IP meeting, he is not focused on the task at hand. He's distracted, and he's saying, are you coming to visit me? Are you doing this? So he cannot make that as far as his being able to write a signature. I know the X, but even if you put an X, he has no concept of what the implications are. And so I think it would be unconscionable, and it would be a travesty to have these clients, our son, who needs so many supports. It would be a travesty, and in a sense, he would be signing away his life if the language isn't changed to address it. Perhaps there needs to be some qualifiers for that population at Wheat Ridge and in the community who are not able cognitively to even discern and make those decisions that would affect their life now and in the future.
We appreciate your comments, and thank you for coming to speak with us today.
You are so welcome, and we appreciate it.
Okay. So our last person to testify is Lynn Crooks.
thank you for your patience.
Lynn, if you could just state your name and...
Oh, I'm sorry. My name is Lynn Parker Crooks. I was here at your last meeting. You may remember that I sent around a little piece of paper that showed that my son can sign his name. It takes up about that much room. Okay. I'm not going to reiterate what you've already heard, but there are a couple of things that I would like to say. If you give my son more than two choices, he's confused. And that is, do you want a cheese, do you want a chicken sandwich or do you want a hamburger? And he can do that, and I'll say, David wants, and he'll tell me, okay? But he can say yes and no and all of that. So I think you've gotten the picture very clearly about the parents that are here that are and guardians that are here that are very concerned. I am so grateful that you have tabled it for getting better words, because it is an endangerment to the safety and the guardianship that is supposed to be there. One of the things that's very important to remember is that you're talking about individual people, individual facilities, individual treatments, and it's a very wide range. There are people who are certainly very capable, and they haven't been treated right, and they have every right to have what they can't have now, and that's very important. But on the other end of the scale are people like my son, who needs to be protected, and he is protected right now, and I'm grateful for that. And one other thing I wanted to say is I believe there's a misinterpretation of the Olmstead Act, and I think it's really important that people realize that what it is, it's a choice. It's not you have to move. It's not we will make you move. It is if you want to move, we will help you move, finally get you into the community. And I think that's really important because a lot of legal explanations of the Olmstead Act talks about you have to do it. No, you don't. It's a choice. And that's what the Supreme Court put, that it's a choice. We're just not an institution anymore. It's a group home, several group homes. And that is something that we want to keep. One more thing that I really think is important for everybody here to hear. I'm reading from somebody else's notes. Colorado Department of Human Services Executive Director Reggie Bika informed us that he will do whatever is necessary to remove what he termed barrier guardians, or those of us who dare disagree that the community has equivalent services for our loved ones. Now, if you know who Reggie Bika is, you know what kind of weight he carries. And he told us that in a meeting. So we're not paranoid. And we're not, if you will talk with us, we're not unreasonable. But we have actually had our guardianship threatened. Thank you very much for your time.
Thank you. Sue, can you?
I'd like to respond. I am the executive director that partners with Director Bika over at Human Services, as well as Dr. Larry Wolk at the Colorado Department of Public Health and Environment. And I want to just clarify, because I think there's a lot of ongoing sensitivity, rightfully so, about the regional centers and this notion that there's this move to close them. I just want to reiterate my support and clarification that Director Bika is not trying to close regional centers, nor is he trying to impinge on the guardianship issues. I think all of us are trying to implement Olmstead, we're trying to implement choices, we're trying to just be certain that we modernize all the work around community living. And so we're very sensitive about it, but I do want the board to hear very clearly from me, and I know our Medicaid director, Gretchen Hammer, and I have talked about this as well. We do have a duty to make sure that choices are available, but there is not any sort of predetermined that regional centers will close or guardianship rights will be impinged on. So I do want to just clarify.
May I respond to that,
statement,
please? Yes, please, Kate. Thank you very much. I appreciate your clarity. You were not at the meeting when Reggie Bika told us he would take our guardianship. He said it in a meeting. And it's important that people know that he said that. He may not have meant it. He may have been angry because we seemed like we were very stubborn, but he actually said, I can take your guardianship away from you. Thank you very much for your time.
Thank you, Mrs. Crooks. Thank everyone for coming to testify on this document. Thank you, Department, for working with the individuals. We appreciate all your time. So we'll go ahead and move forward on the initial approval agenda. If I could have a motion for document 7.
I have the initial approval of document 7, MSB 15-02-11-A. Revision to the Health Programs Office Benefits and Operations Division Ambulatory Surgery Center, parentheses ASC, and parentheses rural, concerning a technical correction to the amount, scope, and duration of services, section 570, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
We have a motion and a second, and we have with us Anna. I can never say your last name, Anna, so I'll let you introduce yourself.
Good morning, Madam President, members of the board. My name is Anna Lukacs. I am a policy specialist with the department, and with me I have Frank Herbst. You met him earlier today. We are here to present the revision to the Ambulatory Surgery Center rule concerning the amount, scope, and duration of the services, and we are bringing just a subsection of the rule for the non-covered services. Section 8.570.5, non-covered services. As you may recall, in the summer, fall of 2014, we brought this rule in front of you to incorporate the language from our benefit coverage standard that we initially had it incorporated by reference. And that rule was adopted. Upon subsequent review of the coverage standard, we identified some technical errors with this section for non-covered services, and we corrected them in the coverage standard. So today we are making those corrections into the rule just to mirror the two documents. The major change was the first two items under non-covered services that you see in the document. They were bundled together in the same row, and they completely mean two different things, so we just separated them. And we added the words in an ASC for the first line. And further down, we removed the word or, which seems to be the word of the day today. I just want to point out that our changes here reflect the past and current procedures and operational status of the ambulatory surgery centers.
Do we have any questions? Do you have any testimony, Dan? No testimony. So with that, we have a motion and a second. Everyone in favor, please say aye. Aye. Anyone opposed? Thank you.
Thank you.
If I could have a motion for document 8.
Move the initial approval of document 8, MSB 14-02-12-A, revision to medical assistance long-term services and support rule concerning community transition services, section 8.553.1, incorporating the statement of basis, purpose, and specific statutory authority contained in the records.
Thank you. So we have Nora Bray, and Tim. Welcome, Tim.
Thank you, Madam President.
Good morning, Madam President and board members. My name is Nora Bray, and I'm the Transitions Administrator in the Office of Community Living. And we're here today to present a revision to the Community Transition Services rule. Community Transition Services has been a benefit
of the home and community-based services for elderly, blind, and disabled since 2006. This revision will implement community transition services as a demonstration service in Colorado Choice Transitions, CCT. So Community Transition Services provides assistance to individuals who have the desire to leave institutional care and to move into a setting where they would be able to receive community-based services. CTS includes transition coordination services, which are the services that actually work with the clients and help them to make the transition. And then it also provides funding for household setup in the community for an individual. Household setup items have often been a high barrier, a large barrier to people being able to reintegrate into the community. So the revision expands the eligibility of community transition services. As a waiver benefit, only those who were eligible for the HCBS EBD waiver were eligible. This revision expands the eligibility to adults, to any adult who is a participant of our adult waivers, except for the spinal cord injury waiver. CTS also currently only makes the service available to individuals who live in nursing facilities. With this revision, CTS would be those individuals who live in intermediate care facilities. For individuals with intellectual disabilities would also be eligible to receive CTS. So it expands eligibility, which is the primary, the incorporation of CTS requirements is focused primarily on that eligibility expansion. In other ways, it expands it adds additional household items that would be able to be purchased from that household setup fund. It adds the first month's rent, purchase of a cell phone for safety monitoring, a bus pass to be used for transition process, a computer that is determined to be medically necessary to sustain living in a less restrictive setting, and also clothing appropriate for the community. Many of our individuals who live in nursing facilities don't have appropriate clothing, so we added that as well. It also enhances the staffing requirements for the program in that the transition coordinators are now required to complete a department-developed and approved transition coordination training, and also a training in risk mitigation planning. Then it also outlines some of the stricter requirements around supervision of our our transition coordination providers. Okay. So primarily it's a revision that enhances eligibility, which makes this CTS able to be used by a larger number of people and for residents of both nursing facilities and ICF IIDs.
Okay. Any questions from the board? Mrs. Hughes?
Good morning, Brigitte Hughes. I'm really excited about the changes that have been suggested here. I just have a couple of questions. One, with the added services, how does that reimburse? Is that through the cost containment monthly, or how does that affect the client?
Sure. Madam President, board members, this is Tim Cortez. So there is a daily cost containment that is applied for home and community-based services programs. People, when they services are authorized, have to be under that ceiling, and it's equivalent essentially to nursing home care costs generally. However, the daily average that's looked at is done over across an entire year span, and so that I believe it's $1,500 that people will have access to in terms of those dollars. So that is just rolled into all services for that entire year. So it has, I think, overall in terms of cost, it has minimal implications for their cost containment.
Great. That's what I was hoping would be your answer. And also, I was wondering, this care coordinator's position, is this established with the single entry point? It's their responsibility to hire that position. Could you clarify that for me, please?
Care coordinator, there's two positions, primary positions that are outlined in the rule. One is a transition coordinator, and they are they work with transition coordination agencies who are agencies that are approved to provide HCBS services and then also approved to provide CCT services. And the other position are case managers. For those individuals who are using CTS through the HCBS EBD waiver, SEP case managers, case management is provided. For those who are using CTS through CCT, intensive case management is provided, and there's expectation that there's a higher level of monitoring for individuals who need that higher level of monitoring. Again, that's assessed as part of the transition assessment process, and so the level of services is determined at that point.
And transition coordination agencies are not single entry point agencies. They're completely separate providers.
Okay. Thank you for the clarity.
Any other questions? Okay, we have Josh Winkler.
I'll try to not pull a Julie Farrar and run that house trip over. And I did get a text that the sound quality is really bad, so on the web, yeah, so I don't know if it's for everybody or just a few people talking. So I'm Josh Winkler, and today I'm testifying on behalf of both Colorado ADAPT and CCBC. As I said last month about the rule that was talked about earlier, ADAPT's been working with the department quite vigorously about improving the CCT program. There's still a lot of barriers. We're a year and a half, I think we're 2 years into the 5-year grant, and the goal was 500 people. We're at 83. So clearly, there needs to be some work done to make this program be more effective. This particular rule, there is a lot of concern around a couple pieces of it, that by rolling CTS into CCT, you're taking away the choice that clients currently have. There's a reason some clients are currently transitioning still through CTS rather than CCT. And a couple of the big ones are there's a 90-day requirement for CCT that you have to be in an institution for 90 days before you're eligible for the CCT program. Under CTS, there isn't that rule. The other one is the intensive case management that was mentioned. Intensive case management has been a huge barrier for many clients because of the way contracts were bid and requirements were made on the SEPs. That wasn't included. So there are not contractual obligations to provide those intensive case management services. So clients, there's been a multitude of barriers to people getting out. Housing for a long time was the largest barrier. There's been a lot of work done between the department and Department of Local Affairs to work on the housing issues, and vouchers are coming available, housing's being found. HUD actually just announced that the state of Colorado is getting a bunch of money for some 811 vouchers. So the housing piece has been, I'm not going to say fixed, but a lot of that pressure has been alleviated. Now one of the problems is people have housing come available, but there's not an intensive case manager available for them. So housing is very limited. You have a voucher available or you have a unit available. It's only available for a certain amount of time, and you only have these $1,500 to spend. So if you spend it on rent for 2 months while you sit in a facility still, then now you don't have money to get that bus pass, to get that computer, to get that. So there's real concern about rolling these two programs into one. And I'm hoping that, and I know there's been a lot of conversation over the last 24 hours with Tim and a few folks in the community. about changing some of this language and finding a way to keep CTS its own unique program and make that available to clients, but still move it into this CCT under the grant where, I mean, one of the advantages, there's an enhanced match on the federal funds. Plus, there's a goal to get a certain number of people out of institutions. But we don't want to make it so people who need that CTS program lose that uniqueness that program currently offers.
Nora, Tim, can you address?
Yes, I'd like to respond to that. Just want to remind the board that Community Transition Services is a benefit of the HCBS EBD waiver and a demonstration service in Colorado Choice Transitions. So, and each of those programs, as Josh mentioned, has different eligibility criteria. For CCT, you need to have been in an institution for 90 days. For EBD, you don't. For CCT, you need to move into qualified residence, which would be an apartment or a family home or a smaller group home. Through EBD, you can move into an assisted care facility. So we're not rolling this into one program. It's one service that is used in two different ways. And the way a client begins the process of being involved with CTS is through options counseling. Options counseling is the point where clients are provided lots of information about options for living someplace else other than an institution. And during that conversation, the options counselor provides information to the client about CTS through Colorado Choice Transition and CTS through the HCBS EBD waiver. The client is then able to choose which one meets his needs. So there's a lot of confusion that CTS equals CCT. That's not true. Community Transition Services is a benefit of HCBS EBD and a benefit of CCT. What this revision does is solely expands the eligibility. And I mentioned that there's required training for transition coordinators and intensive case managers. In that training, the differences in the two programs are clearly defined, and the guidelines and procedures for each of those two programs are defined. So in the training is where you see the difference, but we are not rolling this program into one.
Thank you. Sue, did you have something to add?
And this is Tim Cortez, just to follow up from Nora's, if you look at the rule, which is at 8.553, what you told today at 8.556 is the CCT rule. The CCT rule specifically outlines the eligibility criteria for people who are enrolling in Colorado Choice Transitions. That eligibility is not in the CTS rule at 8.553. In the CCT rule, it does specify that person has to be in the nursing facility for 90 days, and as well as other requirements around qualified housing and things like that. But that is not carried over into 8.553. So essentially what we're trying to do is just create consistency between the benefit between both programs. But the eligibility, it does remain different for EBD versus Colorado Choice Transitions.
Thank you.
And I'd also like to just follow up to Josh's concerns about barriers. Yes, we do have barriers. This is a demonstration program, and what it has done really, really well is to raise issues that have been in place for a long time and has been talked about, but we haven't really worked on them. And what this CCT has done is allow us to discuss those issues and to problem solve, and that's what we do. And it is taking time. And as Josh said, we started with a big issue that we didn't have enough vouchers. And through a process of working with DOLA and problem solving, we now have vouchers. But yes, there's barriers, and we continue to work on them diligently.
Thank you. Mrs. Riley?
I would like to disclose to the board that I administer a county department that includes the single entry.
And I just want to weigh in with Nora's last comments, because I remember some time ago cautioning this board that we were on a long journey of evolving our long-term services and supports, and that we had to be provocative, move quickly, but that we were going to absolutely have a lot of work ahead of us. And I think the latest good news about getting more housing vouchers at DOLA, and certainly we can't thank Pat Coyle and DOLA enough for coming along with us. The governor also is funding a Medicaid crosswalk project with his new homeless director, Jennifer Lopez. But we have so much more further to go. And this is an evolving process. I want to be very careful, though, because I remind this board, and for those of you that have been with us on this journey now for almost 5 years, that we really have come so far. We're not even close to being done, but we have to keep moving forward and aligning things. When we get further into the waiver, redesign and simplification process, there are going to be impacts there where we have to align things. So I just want to put that in perspective, that we're not done by any means, but this is the right step to keep moving forward. And again, really trying to get more capacity in the whole system, because even though we think that there should be more kind of market forces responding, we're not going to see in some of this evolution and progression more movement until we continue to disrupt the system. So, for example, consumer directedness or service-based, we need growth in all areas. And so I just want to be careful that we don't lock into, kind of one modality, or to think that, we're not continuing to disrupt positively. It's like it's stepping stones of progression.
Thank you, Sue. Josh?
I was just going to ask that, because of the concerns, and I'm not an expert in this area, I'm not going to claim that I'm an expert on transitions, but there have been conversations with people who do this every day, transition coordinators and SEPs that are involved, that do have some concerns with this rule. So I would just ask that you not put it on the consent agenda, so it can be, if there's any issues that need to be worked out between now and April, that they can be, and those can be discussed if there are still lingering issues at the April meeting.
Can I make a comment?
Sure.
Thank you, Madam President. I think the crutch of the issue is the statement in the statement of basis and purpose, and the sentence is the revision incorporates CCT requirements. That could probably have been worded differently and a little bit more specifically. And the feedback we're getting is that there is the concern that this requirement is there, and so there's the concern that, yes, the 90-day rule and qualified housing, and that's an easy fix. We can change that wording very quickly. So I would ask that it not be tabled, but that it be approved with or that it moves to the next step with the understanding that that sentence would be changed.
Okay. Any concerns with that suggestion? So we can go forward in looking at seeing a change come with the wording. Dr. Okay. So with that, all those in favor, please say aye.
Aye.
Any opposed? Okay. Thank you. Okay. Looking at the consent agenda, what recommendations do you have to move documents?
So I would move to add document 7 to the consent agenda.
So we have a motion and a second. Everyone in favor, please say aye.
Aye.
Anyone opposed? Okay, may I have a closing motion?
Sure. I move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Health Care Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference.
Second. All those in favor, please say aye.
Aye.
Anyone opposed? Okay. We are now to the open forum for public comment. Okay, we have 3 individuals. If we can start off with Donna Sablon. I probably didn't say that name correct. If you could just state your name and who you represent.
Donna Sablon. I'm here in a couple roles. One is a person, an advocate with CCDC, and a community advocate who we've had a lot of problems with this area. So I think what I need is to ask you for a rule clarification. I'm going to read something and explain. So in the Medicaid notice, CIS or food stamps, you get all these hoopty papers. Well, continuation of benefits. If this notice says that your benefits will stop and you want your benefits continue while you appeal, you must ask for a county conference or a state hearing before the effective date of the action. And I'm going to stop there because here's where our problem comes in. The OAC, ALJ, Office of Administrative Courts, says they sent out this little notice that says, we don't continue benefits anymore. You need to go to the county and get a written letter if they will continue benefits or not. I don't see that here. I need a clarification. I have clients, and one rep was still able to stay months before. We never really had an answer on continuing benefits. I have another client who it's a buy-in, so believe me, I understand that has its issues. We filed the appeal in December 2014 after 9 months of not being able to fix the case. Finally, benefits were really cut off, and we asked for continuing benefits. After several weeks of negotiating with the county to give benefits, I'm like, just grant the continuing benefits. I'm not arguing the case with you. We had to actually go to Director Hammer because we can't get around this system. And a clarification on a rule that I can't see has changed in forever. Now, personally, I got a great notice that says you have benefits and you don't have benefits because we don't know you're unknown. I'm asking for continuing benefits and I'm going to have to argue with the county. How does that happen? And I'm a person with disabilities and I'm on EBD waiver. If I don't know how to navigate it with my support and what I do, how do you expect the reps and the clients who may not even have an advocate, who's in charge here and what is the rule? You offered continuing benefits in the notice, apparently for a reason. I need to know who has authority here and what this rule means, because I can't, if a county doesn't give you a notice, let me explain. If they won't say, we're going to give you continuing benefits. Then we have to request an expedited hearing. That is now 120 days. What would you do without your legs, because you may need a wheelchair, or your meds, or even your glasses? I'm using just acronym, example. For 120 days, how do you expect to function and stay alive? Can somebody help clarify?
Thank you for your comments. And I know that, there's times where the language and the notices are really confusing and trying to make sure that we get clarification on that. So we will take that back and make sure that we get back to you on the two clarifications. First, what the notice says, and then what does it really mean? And we can take that back.
Thank you. And Tess, I know our benefits director's here. Do you want to make any comments about the work that you and Gretchen have been doing to look into this?
And I'd be happy to, sorry, I'm Tess Ellis. I'm the new division director for operations and benefits. So I was trying to hunt down some of my staff to get some clarity, but maybe we can talk aside and I can get educated on the topic, and then we can work together to try to get a resolution. I'm happy to work on that.
Just a clarification, Tess is our new benefits division director. She works with Gretchen, and so she'll look into this further. I know they've already got significant work going on, and I know everything in the correspondence arena is continuing to evolve, just like how we had to overhaul the CDMS system. It is, and Jenny can attest to, how we are continuing to march forward with the correspondence and really putting things through a lean process of notification and whatnot with the appeals. So thank you for bringing this forward, and I do want to reiterate that we did create a new division for this benefits clarification, and we are in progress with it with our new Medicaid.
Thank you so much.
Thank you. Okay, our next person is Josh Winkler.
So I'm Josh Winkler again, and this time just me. I'm just going to be myself, and I'm going to make it as quick as I can. The first thing, actually kind of following up on the benefits thing, last month I testified about the buy-in changes, and as a person who is now, in theory, getting on the buy-in and being in the know, I'm not freaking out, but most clients probably would in my case. So a month ago, I reported my income, the 1st of February. Reported positive income for January that I knew would put me over the 300% SSI, which in theory would kick me into buy-in eligibility. And about a week later, I got a notice about forming an income trust, which I've been told is as of the end of March, those will no longer be sent, because that is very misleading that the only way you can keep your Medicaid is through an income trust, which historically prior to the buy-in was the case. So I go into Peak, I check every few days, see where I'm at, and it just said pending approval or under review. I guess it's under review. And a bunch of random things I didn't know what the codes meant. They were some kind of codes. Finally, 3 days ago, I got a notice that said I'm approved for Medicaid, but I may have a monthly premium. There you go. Thank you. But I may have a monthly premium. That's all I've seen. That's all I know. So here I am now. I've reported my income in March again, and I'm still awaiting. And I will say the Peak system for income on self-employment is great. They actually have. I don't know where they stole it from, but it's broke down just like the IRS would on your income versus your expenses, and they come up with net income. And that part has worked very well. But the noticing is you're out wondering, am I going to have Medicaid? Am I not going to have Medicaid? What am I going to need to do? And I know enough about the buy-in process and what other people have gone through to know that I'm not worried. My benefits are there. I'm not concerned. But the average client out there, I think, would have real reason to be concerned, especially if they knew they were going to go out of the eligibility category they were in and into a new eligibility category like the buy-in. So that was just my quick update on buy-in status and how that's working. And the second thing I want to talk about was, and I've emailed all you on the board so you're aware, I have applied for the Medical Services Board. There is a missing slot, and I'm looking at Gretchen's chair, but it reminds me there is a position that's vacant on the board, and it's been on and off vacant for years, and that is the disability slot, which is by statute that a person with a disability or an advocate for people with disabilities or a family member of somebody with a disability. And then there's another piece in statute around somebody who is receiving Medicaid benefits or has received Medicaid benefits in the last 2 years. And I don't think anybody would disagree that those are important roles to have on this board. This is the check and balance of the department on rules and making sure that the rules that are approved are going to provide the services necessary for people. And I'm not going to claim that I'm the best person in the world to serve on this board. There may be better people out there. And I hope that there is somebody out there. I think this board needs to be the best of the best for all the roles filled on the board. But I think it's important that position get filled with whoever it is that's going to fill it. Because every month that goes by, more rules are approved, more rules go through this board without that vital opinion present. So I would ask the department to work on that. And if people are in the audience listening, or you know people who might be eligible that could fill that role, to put their name in the hat and get their name in the hopper to be considered for approval for the board.
Thank you, Josh. We appreciate your comments. Any questions? Okay. Our next person is Charlene Wiley.
My name is Charlene Willie. Just getting over a really bad cold, so my voice won't hold up. I had sent you a copy so that I wouldn't have to take up your time today, the testimony about the SIS assessment that's done. I'm the mother of a 31-year-old daughter who has a developmental disability. I'm also a non-attorney advocate with the CCDC. And were it not for that affiliation, I would never have found my way through this amazing bureaucracy. I just want to start by telling you that. Most families are not equipped to do the things that I have done to give my daughter an independent life. And I'm here really to tell you how hard it is, and in this particular situation, how much difficulty we've had with the SIS assessment. I see my daughter's now one-off, a pretty typical young woman entering a life, and my story, as I related it to you, kind of, to me, we put it out there. I worked with Julie Riskin at the CCDC, and we brought this forward to the department and asked them to change this. I'm also a member of the assessment tool stakeholder group with, as I'm sure you're familiar, looking to build an assessment tool. There's a tremendous amount of work and expense going into that tool. And I was very disappointed to learn at the outset that the department's decided to keep the SIS, and that's before the process began. I realized that the new tool is supposed to replace the 100.2. That said, there's a whole schema of change. It's very exciting. I think it prepares people in the community like my daughter to enter more fully into a life, a satisfying life. And provides safety and so forth, and allows for really solid person-centered planning to occur. So I'm very excited about that. And that compounds my disappointment to know that the SIS will remain. The SIS is a tool that, the first time it was given to us, I had no idea what it was. And it is very, very confusing. And I found it that way the second time, which was only recently when I've had 5 years of experience and all kinds of training and all kinds of other things happen. It's incredibly difficult to talk about a human being the way the SIS requires, and I think that's the fundamental problem. They ask you to speak in 15-minute increments. How much time does this person need for this? How much can she cook a meal? Well, yeah, she can cook a meal, but what about all the issues of nutrition, menu planning, shopping? Good choices. No, I only want to know if and how many times a week. And I mean, that's how those questions go. After 3.5 hours, the second time, we still came out with a bad result. By the way, the department did get back to me last night. I rescored the cyst that I had. They said that even with that scoring, she would have only moved to a 2. And that's because the cyst missed many issues about anxiety and some other issues that she personally has. But as I said, she's not an atypical person. For a person with a developmental disability, I think it's just, again, we brought this forward to the department to give them a case study, to give them an idea of what's out there, what happened. And the SLR that I was offered, I don't think that's offered very often, honestly, but I can't speak for all CCBs. The SLR showed easily a 3. I mean, it took them like no time to make that decision. So I think that this tool is broken. I really like it. We'd like to see the department embrace the new assessment process that's coming about, and that we kind of rid ourselves of things that have been from the past that don't work anymore. You know, we have a nice, shiny new tool. Why would you not want to use that?
Thank you. Sue?
Thank you for your comments. Again, as we evolve these systems of care and have to be in compliance with our federal departments that require us to have some framework. It hasn't been easy because we recognize the individual needs of the information that we've got to get. But I don't know, Barb or Jed, if you want to respond further. I know it's an evolving process. I know that it's coming along, but we do have to show kind of some accountability and some framework going forward. Do you want to speak to the progression? The first one is today.
Madam Chair, Committee, my name is Barb Ramsey. I'm the director at the Division for Intellectual and Developmental Disabilities. I will speak to the process. Also, I want to just take an opportunity before I start talking to state publicly and on the record that I greatly appreciate the work that I've had with Mrs. Willie. She spent many, many individual hours working with us, reviewing the tools, trying to as we all tried to figure out what our next steps were, and specifically in the testimony or the comments that Mrs. Willie submitted for your review, she referenced a 30-page tool that she was asked to use for a support level review, and I'm very happy to tell you as an outcome of the work that with her that we've totally eliminated that tool and developed an electronic process to collect information we need for support level review directly from case records, which are on our benefits utilization system and our contract management system. So I just want to make record of that. I think we've had a very productive relationship. I would also quickly like to give you a little background on the support level process. So providers are reimbursed according to the cost to provide services for individual, and that cost is directly related to the complexity of the services that one needs. So the more complex the needs, the higher the rate that's reimbursed. We have 6 standard, and those the complexities are measured. The term we use to identify the complexity are support levels. We have 6 support levels. The higher the support level, the higher the reimbursement. And then we have an outlier, we call an outlier for an independent, individualized level on the occasion when the assist assessment plus additional factors don't capture someone's needs. And so that's the process we have in place. Everyone who is measured with the SIS assessment plus the support levels, when those levels don't adequately meet a person's need, because no tool meets 100% or can measure 100%, we have a support level review process which may end up with a person having 1 or 2 doesn't matter. Whatever the review is, increase in support levels, and when a person's needs exceed the standardized support level 6 rate, we have the individualized process. So our support level process is intricately involved with the rates process that we have in place right now. What we're doing in our long-term care system, and as Director Birch referenced, we have a great many activities underway, one of which is looking at the new assessment tool. Another will be in our waiver redesign process, how we're reimbursing for the services that we currently provide. Those will all occur on a step-by-step process, and we are considering overall how the SES assessment relates to the rates and the ability to measure outcomes. One final comment I'd like to make is that we are working in our Office of Community Living with the HCBS strategies to develop the new assessment tool. That's the work that Mrs. Willie is involved with, and HCBS strategies is developing a crosswalk with the SIS assessment and the other tool so that individuals who are being assessed for services in the IDD waivers do not have to undergo duplicative processes. We're just not there yet.
Okay.
Well, for my part, I can say, having seen that crosswalk, it doesn't look quite that smooth to me. It looks to me like I don't know where the data is going to come from. The SIS does not provide the data that people need to do a plan. And if you talk to case managers today, they'll tell you that. They end up sitting down with the family and the individual to actually go through what they're. The SIS is just not a good tool for communication. I don't know how else to tell you that. It just simply doesn't work. So what I saw on that crosswalk, I am not a professional, so I may be misinterpreting it a little, but it looks like everybody else goes through with the new tool, except the IDD. They go through, and then there's 2 steps for that. This includes the SIS assessment and something else, which I assume would be a new tool. Whatever it is, it's completely different than other waiver participants are required to do. That doesn't make any sense to me. To me, the severity levels and all these things that the SIS is to provide today, which I think we can establish that it doesn't work at least part of the time very well at all, will be done with the new tool. So what's the purpose of forcing people into the SIS? You know, I spent 35 years in private business doing a lot of planning and product development and such things where we're required to work with systems. Usually what would happen is there's a lot of resistance to change because it's hard to change, especially for big operations. But this seems to me to be just something from the past that's making its way into the future. And I just, from a systems perspective, it makes no sense at all to my brain. And I'm not caught up in the system. I don't live in the system. I readily admit that. But sometimes there's an advantage to being like that, where you're just looking at a diagram and say, that doesn't make any sense. And that's the way it struck me. Apart from my personal experience with the SIS. And in talking to people like Julie who have broader experience with many more people in the same system. So I just don't understand why we're keeping it, except that there is a need to control allocations. I totally get that. And we all have to live with that. But beyond that, I don't know why there can't be some other means of doing that that's with the new system that makes sense. So we're building a future and not holding on to the past or elements of it that make us behave the same way we always have. The other thing I'll say about the SIS is it doesn't meet the CMS requirements for person-centeredness. There's no way that it does. Whereas the new tool, of course, that's a big goal.
So, Mrs. Wiley, would you feel comfortable continuing your work with the department and going ahead and continuing to make some of those suggestions so we can look at what does work? Sue stated we're looking at new things. What can we do better? And I think that that's what our goal is. What can we do better? We may not always know that. So that's why we depend on people like you to come and help us to understand what do we need to do better.
Well, I guess where I would come from is the idea that you start off with embracing the future and not the past by saying we plan to get rid of the SIS. Goodness, I mean, I know you can't do that tomorrow. But I think, to let go of the decision where we're going to keep the SIS and move along, I mean, that doesn't make sense to me. What would make sense to me is, well, we'll give ourselves a timetable and a transition plan for moving from the SIS to another means of doing this. That would make sense to me. But I need to see dates and times and commitments. Otherwise, I don't feel comfortable because it's just too easy. I do it all day. I mean, we all do it. We all hold on to things we shouldn't longer than we should.
So, I want to reiterate to the board that, and really under the executive order of creating the Office of Community Living and transferring DIDD over to the department, there is a forward progression. These things do take time. There are components that are in place. We have to balance our federal responsibilities. We are moving towards person-centeredness. The department does have kind of a roadmap of how these things are on-ramping or off-ramping and modernizing. Transformation and change is really hard. We are trying to do as much kind of inclusion and participation in the process, balancing all of this as we bring it forward. And I want to thank the board and our stakeholder partners and the staff. I mean, this has been an enormous lift. This work is not done by any means, but we are on this path together. So it's with that I make the commitment as the leader here that we are going to continue to balance the process. We're going to continue to modernize and bring forward the best of ideas, and all the while we have to negotiate these things with our federal partners. And I do want to thank Barb and Jed for their leadership and yours as well, because I do, I get the sensitivity about balancing all these variables and factors.
Mrs. Blakely?
Christy Blakely, I just want to thank you, Mrs. Wiley, for coming forward and sharing. I'm one of those people who has been through the system with my own daughter, and I agree that it is not anywhere near a perfect tool, and would encourage other people to join me in sitting in one of those meetings on a SIS evaluation, because it's very eye-opening in the difficulty in how we evaluate. But we are restricted, and so I just really appreciate your time, but understand that there doesn't seem to be a perfect tool at this point in time. So thank you.
And we continue to encourage you to continue to work with us so we can look at some of those things. So we want to make sure that you continue that with us. Any other questions? Thank you. Okay. We did have the hospital provider fee update, so you had that written update. We also had the Child Health Plan Plus quarterly report. We do have a change. The customer contact center overview, we've moved that to next month. And so last but not least, we'll have Sue give her department update.
Great. It's great to be with you all again. I feel like it's really one month that I see you, but I think that's because time is passing so fast. So it's great to be here. Many of you have reached me in between meetings or when I do see you, so please continue that, because I always welcome your feedback and meetings. I want to just share with you some great successes. First, about open enrollment updates. Connect for Health this week updated its enrollment number during this open enrollment period that just ended, and more than 141,000 people enrolled in private coverage. 54% qualified for financial assistance. Average monthly premium assistance around $230, right under. Nearly 25,000 enrolled in dental plans. And during Connect for Health's open enrollment, we saw 76,194 new Medicaid enrollees, about 3,700 in CHIP Plus. We know there are challenges in the system still. We're working through the technology, but I do want you to understand, of the state-based exchanges in the country, we were fifth strongest. Again, we absolutely hear the consumer concerns, the broker concerns, and we are working closely with Connect for Health. Brenda here deserves an award. Gary, my counterpart over Connect for Health, and I pretty much are on daily, if not weekly, meetings and calls. But again, it's another journey. It's not perfect, but we are moving forward and advancing in this country. I remind you, some states don't even have, or they have really a kind of minimal lift or the challenges of federal exchange. Not perfect, but it's definitely functioning. Right. Definitely, we have lots of meetings about optimizing that system. Also, I wanted to make sure you were aware that the Division of Insurance determined that there was not going to be a special enrollment period here in Colorado, that it was not required. And the federal government has announced that they are having special enrollment periods. We are a state that is not going to do that. And that is under Division of Insurance purview. And it is great for you to serve as dignitaries if that confusion comes up. There will not be a special enrollment period. And just so you know, they made that determination because of the cost to Connect for Health, the cost to the carriers, the assistance sites, certainly to us, and we already have those that are enrolled. It's not really equitable to the people already paying 2015 premiums, and really it's unenforceable. And we just think that it's really important that we stay the course, and that we've had such tremendous success that we really didn't need it in our state. You've heard all sorts of talk today about long-term services supports and our community living efforts, but I do want to put on your calendars 2 huge milestones coming up. We will be celebrating the 25th anniversary of the ADA on July 26th. Colorado really was ground zero for that movement. It was our partners, certainly not the department, but our partners, and we have kind of walked that path with them. And Olmsted, the 1-year anniversary on July 30th. So I do want you all to know that we will be creating some greater awareness and celebrations, and you're all invited as we establish what those parties look like. We will let you know. The Community Living Plan is a proactive step that Colorado has taken to respond to Olmsted. We're one of a few states who have released an Olmsted plan preemptively rather than because of a lawsuit. And we really are working hard between the departments to really continue to progress Olmsted. But you are getting a sense of this disruption that we're creating, too, because I think a lot of people have in mind kind of the perfect end, and we have to be careful that we keep just having forward progress and really keep evolving these systems very carefully. And I do want you to hear from me that we're trying to minimize unintended consequences as we go through this process. There are lots of imperfect tools. The OASIS tool for the home care environment, the hospitals would tell you we have a zillion perfect tools. And we are working with the best that we've got in this developing process. Anyways, we are also within the Olmsted Plan and the Community Living Plan really working closely with Department of Human Services, Department of Local Affairs. In the No Wrong Door arena, we received a $225,000 planning grant from the Administration on Community Living. And, we are striving to get these well-designed systems that inform people of their long-term services options, assist them with preventing unnecessary institutionalization, providing more person-centered transition support. And again, these are really lofty aspirational things, but they need kind of incremental progress. We've convened with the Department of Human Services more than 40 stakeholders earlier this week to start creating the plan for a No Wrong Door LTSS system enhancement. And we will be submitting a plan in the fall, and we may be eligible for some federal implementation dollars about this No Wrong Door process. We also have really moved more aggressively on the person-centered transitions to the community, and we are working very closely with the Office of Behavioral Health, which is over at the Department of Human Services. OBH has funded for this transition support forum, the Mental Health Institute, and we're sharing best practices and lessons learned that might be unique to working with folks with mental illness. And I'm really pleased to tell you, just like a few years ago, we had some exciting opportunities about reproductive health and private foundation support. We have some great meetings next week with private foundations about how we can use more in a more coordinated way for folks that somehow get into kind of our law enforcement realm with mental illness. And so I'll be reporting back to you as we have more of these meetings and more of this opportunity that evolves because of SIM. So again, it's that forward movement, but it's kind of hazy, but it's not, it's very exploratory, but we know there's a better path forward. Another really positive success on dental benefits. I wanted to let you know a little bit about our dental provider enrollment. Our ambulatory services organization, DentaQuest, partnered with the Colorado Dental Association on the Take 5 campaign. And thus far, we've got 179 dental providers committed through December of 2014 since we started that initiative. DentaQuest is using geomapping to identify areas in Colorado with highest provider need. And we've got outreach specialists and provider relations reps that are assigned to the regions in Colorado to get kind of boots on the ground perspective. And we are really trying to add 470 billing entities and providers since March of last year. And there's another 53 in the process of enrolling. So we're really trying to do a lot with our provider outreach as well and making kind of our efforts around getting providers enrolled into the department easier. Based on the claims, in our current fiscal year, we've seen a 28% increase in the number of providers seeing more than 30 members. That's compared to the fiscal year 2014 data. And there are nearly 1,500 Medicaid dental providers right now in our roles. And we are really pleased that there is more information about healthcare workforce initiatives on our website, and Judy can send you the details and the links on that information. So we are continuing to see kind of an uptick of folks that want to participate in the Medicaid program, and we are actively engaging and cajoling, nudging people in to keep working with us. I mentioned earlier about the overall successes of enrollment, but I want to take you deeper into our successes with the Accountable Care Collaborative. So we currently have about 800,000 clients enrolled in the Accountable Care Collaborative framework, and that's like unbelievable to me because I can remember the first time I reported to you and we were like under 81 panels. And that's like unbelievable that we have just mushroomed. It's really, really exciting. 65% increase over the last 12 months. We have approximately 600,000 of those 800,000 that have a primary care medical home, and that's a 7% increase over the last 12 months. This is just an enormous shift to have this many people in coordinated care systems. Really exciting. The total cost of care, 4.5% below the statewide target. So many of you probably saw the op-ed piece this week, and this again is showing how we are really pushing to bend that cost trend and get kind of those coordinated common sense services going. Our 30-day hospital readmissions are 10.6 below the state target, and our high-cost imaging is 6.8% below the statewide target. I mean, you guys, this is an enormous return on the investment in this framework that we've pushed and built. So, like, that's not enough to report on. Let me tell you about some of our innovations. In the spring, we launched the Accountable Care Collaborative Chronic Pain Disease Management Program. It connects a primary care medical provider with a pain specialist to better manage our patients' chronic pain. This is an e-consult program connecting the primary care specialist to really consult on our patient cases. And the ACC Medicare Medicaid program, formerly we call that the Duals, which was implemented in September 2014. There are 23,316 of our clients that are enrolled as of March 2015. And our RICOs are completing service coordination plans for each of those clients. And they're focusing on what the client's goals are. And the disability law in Colorado is hiring a full-time dedicated ombudsman to serve these clients beginning in the spring of this year. So it's very exciting, again, that we're also bringing in the duals into the RICO framework. We did issue an RFI some time ago about the ACC version 2, and we got over 120 submissions for information about how our reprocurement of the ACC should play out. And we have also input from focus groups. The committees certainly have given us responses. We are going to be issuing or sharing the full text of the RFI summaries this spring. And we just received JDC approval for consulting support in developing the next version of reprocuring the Accountable Care Collaborative, because those contracts have to play out in the next 2 years. So we're really pleased with the future of our Accountable Care Collaborative framework. We are forging ahead with that work. It is Colorado's commitment of how we're going to run our Medicaid programs and well into the future, and we're getting great successes. I wanted to let you know about the application to extend Colorado's Section 1115 demonstration project. The background, there are 3 main objectives because we want to continue to decrease the uninsurance rate for pregnant women. We want to increase prenatal and postpartum care for women, and we want to increase the number of healthy babies born to pregnant women. This was initially approved in 2002, and under this demonstration, Colorado expanded the income eligibility level for uninsured pregnant women from 200% FBL up to 250. On April 15 of this year, we intend to submit an application for an extension of this demo, and it'll give us the authority to continue to get matching funds for the uninsured pregnant women in the Medicaid state plan, because that expires in July of this year. The application will request an extension of the federal authority for Colorado to continue receiving these matching funds for these populations of folks. There'll be public noticing, there'll be a draft application and budget information. I think that's actually already done. It's on our website. And there is a meeting on March 16th, and the deadline for written comments is April 9th. Also, I wanted to let you know that the School-Based Health Center Improvement Project, we refer to it as the SHIP, final report went out. It was a 5-year, $7.8 million demonstration. It was funded by CMS. And that team worked with 22 school-based health centers in Colorado and New Mexico. It demonstrated that school-based health centers can be really effective in the medical home model, that there are strategies for quality improvement of care within these SBHCs, and that these centers really have a strong ability to engage youth, ages 10 to 18, in their own care. And the findings created policy recommendations that were delivered to CMS, to different Medicaid programs, to different health departments, insurance plans, and provider systems. That final report is available to you on our website, and Judy can get you a link to that as well. I think the last area that I want to just mention is about PEAK and CDMS enhancements. As of March 22nd, there will be numerous enhancements that roll out. There is a huge push for reducing application processing times and errors. It'll improve overall client and applicant experience, and it will also have better medical correspondence and forms that are available in both English and Spanish. The shared eligibility system enhancements will allow for certain data that will be auto-populated so applicants won't have to enter their information more than once. The My Benefits page in PEAK will be modified to include the advanced premium tax credit and cost-sharing reduction amounts if applicable, and then there'll be additional help text added. And clients can choose to have their correspondence sent to an authorized representative. So those are the things that are coming up soon. It sounds simple. There are a million details in all of this. It feels like a million technology vendors. But we really continue just to have enormous success with our PEAK app and all of the enhancements that we've we've made. As I told you before, it's a journey. We're not done, but there's a very vigorous calendar of system improvements that play out throughout the year. So with that, I'm going to stop and open it up for questions, and Jenny's first.
So that the data on this most recent open enrollment program is very compelling. I'm wondering if there's a way that either of you know to get it by county so that I could share it with my county commissioners.
We do have it.
And Jenny, I sent out an email this week to all the counties with how to break out and get your county data. I will refresh that email like just yesterday. Maybe I
haven't even seen it.
Right. It's in the last 48 hours, and it came from me, and I will refresh for Larimer because you can pull down your very specific county data. Do you know what I'm talking about?
Yeah, I know what you're talking about. Yeah.
Nice.
Yeah. Yeah, it's really neat to look at the breakdown even with ages and everything. So.
You know, one thing I will say, and Jenny, you and Brett are experts in this, but for the rest of the board members, you know, you all, as you hear about concerns or complaints or the challenges of some of our last folks that we need to find and get insured, they're going to get increasingly more difficult because there's, I can't tell you as we review some of these folks that are kind of in the system, delayed in the system, the income, you know, they can work for employers with different names and numbers and the seasonality of jobs and the complexity of the households. And so I do think, you know, we do have to gear people up too. For those that have not been coming into the system, those that are coming in late, there's reason why with all their complexities. And so it just really has kind of strained.
I totally agree with Sue.
Our abilities, because these are really challenging cases. So I do think, you know, as you hear about situations, please don't feel bashful about directing any one of us, copying us in on emails. Don't send us PHI, but protected health information. But please let us know so that we can get the right tactical teams on these, because these are really complex cases. Would you not agree?
I agree. I always think of a spider web, and you know how it just, you try to figure out where does it start and where does it end. That's what I think about with these cases because they are so complex. Information, and the funnier part about it is as we're trying to untangle, the customers keep submitting or somebody keeps submitting information that just keeps compounding what we're trying to fix. And so it's been quite challenging with, you know, those individuals that we're just trying to figure out how do we get them to completely finish. So.
It'll
make hyperlink right to Larimer County data. And I mean, the good news that you want to remember here is the 80-20 rule. I mean, about 80% of the time, most peoples are getting through our systems. Ours, our peak system, or connects 80% is a little generous, but most of the time, people are getting through with a no-touch kind of paperless process now, and the interfaces and things are working. But when these complex cases are still in our system, they really are complex. So please, there's a reason, but we'd like to know about that so we can really dig into that because this technology will get better. But we were awarded, and our federal partners recognize us all the time as the leading state in the nation that has delivered on real-time eligibility.
A lot of positive stuff to end, even though we ran longer. So, any other questions?
Just one other comment. The notion of geomapping dentist availability for Medicaid clients is a good one. I want to applaud you on that. It could also be, I don't know if it's been done for primary care providers as well, or specialists. It'd be interesting to see that. Is it available?
I can't answer that about specialists, but I believe we already have that mapping available for primary care. Let me ask Marcel Case and Gretchen to come back at a future meeting. It might not be this next one, but we would like to come back with some workforce provider enhancements, because we're keenly aware that, you know, we've been client-centered. We're also trying to be provider-centered about really upgrading and modernizing provider enrollment issues. And you'll see that really come to light as our MMIS takes off. So we'll come back at a future meeting about workforce.
It would be interesting as well if you could map
people with certain abilities, particularly in rural areas, master's prepared social workers, for example, or ATs, OTs, LCLPs, those sort of things, because it helps also for us to make a case when we are writing for grants, because there aren't anyone, the other thing for the CLIA waiver, for example, musical therapists, they aren't there.
So I will bring that up with Dora, because Lauren Larson over at the Office of Health Professions will probably have a lot more ability to drill down into that through licensure. We don't have that line of sight, although we could partner with them as we need information, and we can certainly, again, work closely with Dora as well as Office of Primary Healthcare over at CDPHE.
Because I think that the two would dovetail really, really well when you're making a case to the feds that we need to extend these particular programs because the providers are not available in whatever capacity that is.
To back up briefly, Mark Williams sent me a message that says we do have geo-mapping on the provider feature
On the website?
on the find a provider feature on our website.
To navigate the website.
I don't believe that's what he's looking at. Like, we right now have some beautiful maps about Medicaid debt schools.
Yeah, that's what I'm more interested in.
I don't think, Mark, I think we have it from a client perspective of where's the closest
I'm more interested.
hospital in here. But we will look at it from a workforce lens.
I'm more interested, yeah.
It is evolving, and it's a big part of our SIP program.
Yeah.
Anything else for me? I do want to thank members of the board. I know many times we deal with this issue of wanting everything to just evolve and get there, and it's a long process. And thank you for your attention and your time and all the great information and requests you send us as well. We really appreciate your service to this board.
Thank you, Sue, for all that you do with the department, and thank you, board members, for your time today. We are adjourned, and thank you for your patience as I tried to figure out what I was doing today.
Good work. Good job.
Great job.
Good job.
There are sandwiches.